change the.
If it's so old, why do they keep talking?
Yeah, I think it's exactly the same as we have exactly the same the sentence that you probably have some.
Yeah, but from our side, I mean, we already figured out what we still need to talk.
It's going. Okay, thank you very
I mean, it was saying if you have members, very close to.
Thank you.
That's a lifestyle.
Maybe they already like changed the
You see that for us it'd be more interesting to discuss who is the people using it.
Yeah, of course, also, because the first question is, you know, what succede with
Okay, then now at least I have the background.
That's what I'm discussing, the technical, why we don't use this.
The info? That is on all things.
I don't know.
Well, see, there is no problem.
No intervention.
What's the format like? Just.
No, you didn't ask me, do you want to talk to Inta?
But why?
I have no special reason to say no.
No, because for those who have the microphones,
The others,
the room
are more interesting, or there are people who can use stuff.
Jest three more minutes.
Yeah, but we don't do anything.
I would say that might
Yeah, well, I will tell you what comes up. There is a meeting out for.
I think if you send the slides, we should talk.
So it's from there.
For the introduction section. No, I don't have. I didn't receive them. This one I didn't. For the welcome and opening remarks.
Give me.
I didn't get them. For the introduction.
Okay, but that's for the introduction. I'm going to send notes in CARDIOCARE. Dr. Steve, please.
Yes. Thank you. Go. Can you send?
Okay, this is there. My funny name here. Well, first of all, thank you for coming. Good morning, ladies, one lady and gentlemen. I am Riccardo Steggiano. I am one of the founding father and the first chair of the Council of Cardio-Oncology for 2018-2020 period. I would like to spend a couple of words to present the European Society of Cardiology, the Council of Cardio-Oncology, and the Regulatory Affairs Committee of the ESC for people that don't know this. First of all, a very, very welcome to everybody, and thank you for coming. I hope you all will enjoy this meeting. The ESC was founded in 1950 with the aim to reduce the burden of cardiovascular disease. It is the largest society of cardiovascular diseases in the world, with more than 102,000 members, generally clinicians in the field of cardiovascular disease, but also nurses, allied professionals, and so on, from 57 national cardiac societies from Europe and of the Mediterranean area, and from 47 affiliated cardiac societies of countries of all the world, from Southern America to Australia and so on. And all these people are collaborating with 20 other special capabilities. In fact, the ESG has 7 associations. Oh, no, sorry. 7 associations, 15 working groups covering all the fields of cardiovascular medicine, and 7 councils. There are more than 2,000 volunteers working in committees and constituent bodies, in board constituent bodies, and more than 5,000 cardiologists contributing to the Congress, to the writing process of the guidelines and consensus documents and so on. Moreover, we have more than 200 people included in the study, and we have a huge example of these people. I would like to thank Elsa and Fernanda for the organization of this meeting in the morning. The ESC has 2 administrative centers. The first one is the European Heart House near Nice. The second one is where we are here. The scope to have an office in Brussels is that of engage dialogue with the European Union entities, Parliament and the Commission, to enter directly in communication with the policymakers and the multi-stakeholders advocacy group, like other association of medicine and very importantly, the patient association. The Council of Cardio-Oncology was created in August 2018 to reduce the burden of cardiovascular disease in patients with cancer, mainly cardiovascular disease created due to cancer therapies. The Council is active in all the areas of the strategic plan of the ESC: education, congresses, membership, advocacy, research. About education, I would like to remember the guidelines published in 2020. And in the activities between advocacy and research, I would like to remember also the Resilience Project, that is another Horizon 2020 project in the field of cardio-oncology. It's strange that the titles were red, the bright red. Okay. Anyway, we have 1,800 members with a certain balance of gender, mainly young people. And I hope that all of you coming from Greeceland and Italy will enjoy that the number of members of Greece is very high in the Council of Cardio-Oncology. Another important entity of the ESC is the Advocacy Committee and its Regulatory Affairs Committee that was specifically set up to provide aid, the head of expert, about the EU regulatory rules in terms of different fields and very importantly, a huge work of the Regulatory Affairs Committee was to study the European regulation on medical devices, and very recently has been published, the week ago was published this paper about the adoption of health solutions for the treatment of patients with cardiovascular disease. So I think that this paper could be very important for also for the work of the people involved in CARDIOCARE. I hope that many of you would like to join the Council of Cardio-Oncology. I'm remembering that the membership is totally free. You only have to go on the webpage of the ESC, is cardio.org/cardio-oncology, and subscribe to this. Thank you. I have ended. This is my mail. You will receive also a link in the slide to the activities of the Regulatory Affairs Committee. So going to this link, you will see all the papers and the statements published by the Regulatory Affairs, and I think that could be interesting for all. Thank you.
Moment. You'll be right there.
Nicola will start my presentation, but basically I would like to thank all of you for having that meeting, especially Nada for organizing that meeting here. And it's a great pleasure to be here. And also Ricardo, who always is with us in these meetings. And our, let's say, external experts that we invited here. And I think that this is very important for the project itself because we are going, let's say, from the stage of research, of the clinical trial and what we are doing to the next step to see what is the pathway, what we have to do. If we like, let's say, to use the results of this project within, let's say, in our society, within the clinical practice and so on. So again, thank you. And today we'll start, the agenda that we have prepared with the European Society of Cardiology. People prepared the agenda here. And we have several speakers. So from the beginning, as coordinator of the project, I will try to give you the framework, especially for the outsiders, the experts, to understand what we have in our hands. And this is the purpose. And also we'll keep it as short as I can. So don't worry about it. Okay, usually when you see too many slides from my side, okay, my core workers there in fourth, they are laughing with me, but no, I'm starting the presentations. Okay, but the CARDIOCARE project now closes the 30th year from the beginning. And it actually targets one thing that Ricardo mentioned very well, what is the cardiotoxicity after cancer treatment. And basically, this is what we're trying to do. And we focus this project in breast cancer, especially women after 60. Initially, the project that was 65, but we have modified, the target group to have women above 60. Then, okay, we know that the use of targeted drugs cause cardiovascular complications, and this is basically what we focus. Okay, it's very common. It's something that happens, and many people. You can see a detailed, let's say, description on the right. You will have the presentation, so you understand basically how the cardiovascular toxicity comes, let's say, as a result of that, having effects on the cardiac structure and function, and also clinical manifestations. This is the general, framework where we're looking with this project. What we're trying to do is to use, let's say, registries, existing cohorts and data with women and cancer patients. Actually, we don't specify the project if they are women or men, but basically most of the project speaks about women because, you know, if the cardiologists come here, they will say that most of the cases are women. And we have data, we are performing a multi-center clinical trial that I have to admit that is a very difficult one because it's very complicated. There are many things that we have to gather. And actually, we're trying also to implement through this clinical trial any health approach to assess the efficacy of behavioral and psychological interventions on cardiotoxicity. So we're doing some type of intervention in this. You will see how we're doing that because it's part of the work that we have to assess and see the regulatory map for that, one of the things. What data do we collect? Clinical, imaging, omics, biomarkers, psychomarkers, intrinsic capacity, wearable sensor data, and of course, data coming from our e-health applications. And I'll give you details, and some of them are questionnaires, other data. And actually, we exploit those data using machine learning approach because we like to develop a risk stratification tool or strategy. Actually, there are tools. It's not just one tool in risk stratification. So you can see that the first is that we have an e-health application that we're using, you know, collection of data, risk stratification strategy, and actually we're trying to improve finally the management of these patients being at the risk of cardiotoxicity. This is basically the scope, the overall scope of the project. Here I have, let's say, the three pillars where we have the project going, early detection and management of cardiotoxicity with the tools that I mentioned above. In the middle, patient-oriented tools, which are the health-based supportive interventions to improve intrinsic capacity and monitor cardiotoxicity and also quality of life. So, you know, in the first, let's say, it goes mainly the machine learning approaches for the risk stratification, early detection and management. Then we go, you know, to health applications, to the health that I mentioned before, in order to support, let's say, and improve intrinsic capacity and quality of life for the patients. And the final one is to make, let's say, the treatment of or the care or to make a different management, let's say, approach through the effective risk stratification and cost-effective healthcare pathways. So there are three things that we have to do. And actually, that now that we're working on that is the time to go one step further and see how we can implement that. Of course, one of the things that we have to understand is the cardiotoxicity definition. We consumed a lot of time in this direction within the project to understand what is cardiotoxicity, because this definition comes from September 2022 for us, at least, as a public. And the data that we received were belonging, you know, to another definition of cardiotoxicity. So we spend a lot of time, you know, especially with retrospective data to understand what is cardiotoxicity. But we have four, let's say, four things here. If one of those applies, then we have cardiotoxicity for the patient. So there are, let's say, some markers already that we have to follow for the cardiotoxicity recognition. Again, here is what is the CARDIOCARE vision. The what is that we have prevention, stratification, early detection, treatment, and intervention. The how is collecting data, imaging, clinical data, other data from wearables. We're building risk stratification models, and then we're building the CARDIOCARE solution, which is very important for the regulatory purposes, the diagnostic support, the therapeutic support, and the prognostic support. And of course, okay, who is doing that? Okay, this is the ecosystem for us. The first is clinical oncologists, cardiologists, geriatricians, psychologists. All those specialties are included. It applies to cancer patients, Okay, and we provide, let's say, better monitor and evidence-based best practices for them. This is actually who is behind that. Now, the main outcomes from that are the structured data sets, the retrospective and prospective. You will see that from the prospective, we are collecting a lot of data, and if we reach up the number of the patients that we target, then that will be a very rich database, not only for the product, but the cardiology community too. mHealth Solutions, IT research infrastructure to collect the data and models and algorithms for personalized patient monitoring and therapy selection. This is what we are ending. I'm starting here giving some details, let's say, retrospective data collection, around 1,600 patients from 5 participating centers, clinic data, imaging, biomarkers, quality of life data. We have analyzed those data. We have extracted some of the models that you will see next. Then we have the prospective study, and we will use this prospective clinical study apart from collecting data to build, validate the risk stratification models. This is one purpose, and also to assess the patient acceptance, compliance, and potential efficacy of the proposed interventions. So the clinical study is twofold. One is to build the risk stratification models, on the other to see the acceptance, compliance, and potential efficacy of the intervention that we're proposing. This is the part of the data. Now the second one, the health application. This is a very nice health application. Okay, having several modules that you can see here with the details on the modules, and also those modules are completed by those modules. So this goes with the patient. Of course, the patient has in the other side, okay, because we have this mobile application, we have built the IT infrastructure that I mentioned before. We have a server, which is the CRF that we have built in order to collect the data. Alexander is here and Dan can give you any details about that. And on the other side, we have built the CARDIOCARE server where we're collecting the wearable data, the imaging data, and whatever else. So we have built that for that case, and I think that is a case that can be reused in other examples. This is how we are collecting the data here, and actually we prefer to, let's say, to have scalable models so we can enrich that and not leave it just as a core platform. Going to the risk stratification approach, we have a multi-model approach, so you'll understand what I mean by that. Collecting clinical data, building some models, then extracting features from images, building other modules. We have also the wearables, we're building other modules, and we integrate all of those to extract the risk stratification. Here you can see the 3 different, let's say, parts of the risk stratification models. One is based clearly on non-imaging data, then we have the imaging data, and this is the wearable stuff. But actually we have a wearable which is for ECG, a wearable which is a wristband, and also we have a hand grip to understand the frailty and so on. But this leads only to conclusion about the risk capacity and quality of life. The others, you know, it's risk stratification models, and they have to be mixed. So you can see here how is the proposal to be mixed, and actually what is the outcome, okay, from imaging and from non-imaging, or the fusion of both data in order to predict if someone will develop cardiotoxicity within the next 12 months, because this is the limit of our clinical study, the data that we have, or predict cardiotoxicity in a certain time point. You will see those 2 different graphs, and here is the integrated model that finally we like to have. Of course, we have, you know, in the non-imaging data, we have omics and so on. Here is a very simple example of what do we mean. We have as model data input in the first case, you know, the baseline, and we estimate what will happen on month 12 or up to month 12. or we have, let's say, and this is use cases, prediction of cardiotoxicity within 12 months after treatment start. You can see what are the data that we have at this time. And of course, we have some data from the prospective study, which is ongoing. So you will not see too many data from the prospective study. Then these are the features that we're using. There are many features in order to train the models. And finally, this is what we're getting as classification accuracy. For the retrospective studies, around 68%. It's a little bit better because we have adapted the models and so on to the prospective study, so it's 75%. Technical details exist for that, but it's not. There is no a reason to go further to that. And of course, is the prediction of cardiotoxicity risk at its follow-up. And what we mean by follow-up, month 3, month 6, month 9, or month 12. I presented the month 12 before. And again, for these cases, because we have more data now, in these cases, you can see what we have for prospective, what we have for retrospective. And actually, in this one, you will see how we achieve, let's say, for prospective, let's say, it's around 70%. For month 3, for month 6 is around 72%, and so on, the accuracy of the model that we have developed. And of course, we have another use case, and actually we evaluate the potential cardiotoxicity progression markers, and we're following, details, about the echo markers. Echo, is something that is used very often by cardiologists here, and you can see the cardiotoxicity p-value, the time p-value for different, let's say, echo markers, imaging ones, and then we have more on potential blood test markers that can be used for that. In order to proceed with markers and so on, we are using an approach adopted by Nature in a paper. Nature is a pipeline that we're using. And of course, another use case is the prediction of quality of life decline that we have here. And we have used, several functional scales, several symptom scales that you can see here. And then we can produce a high row score for the global health status, which is the high quality of life, which is something better. And you can see what we have done from the retrospective data for quality of life improvement and quality of life decline. But of course, the number of the patients that we have quality of life data, as it happens in the retrospective data, it was a very small number of data. But finally, we managed to have that, in accuracy around 70% again. As you can see, this is the accuracy that we are receiving always. And of course, we can predict different, let's say, cardiac events, within 12 months after the treatment start. You can see the events that we can predict. And for those events, we have the data. But as you can understand, as you are going to, to events, you are going to less and less patients per category. And this makes our life very, very difficult. And here you can see what exactly we have from the prospective study up to now. Okay, and of course, this is work that we're doing and continues. There is a second work that we're doing, and this goes very well. This imaging, it will be presented by Kostas later on, so I'm not giving a lot of details in that. But you can see how we're doing the work here. We're doing, let's say, a multi-structure segmentation, then we're extracting radiomic features, and then from that we can extract, let's say, a re-stratification model. For the wearables now, that will be explained by Manolis what we're doing. Later on, we assess biomarkers for frailty and stress and anxiety. The data are coming, as I mentioned before, from wristband, the polar, the heart grip, and also the smartphone, which is, what goes to the patient. That actually this created at the beginning of the study a lot of problems because women above 65 having cancer to have all those things, sometimes is difficult. But the predictive outcomes here are intrinsic capacity and quality of life, not risk stratification in the classical risk stratification. But of course, this will be evaluated, during risk stratification in the integrated model. You can see some of the results that we have received from that, but this will explain, by Manolis later on. We are starting getting nice results, especially when we're doing, let's say, the principal component analysis and we'll compare to PCA features here that you will understand what happens in two clusters. Individuals with sedentary lifestyles and sleep issues with potential lower quality of life, and a second cluster with potentially higher quality of life, which are active and so on. Of course, when we're doing that, another thing that for the people that are with us today, there are some already available tools, but there is no any integrated tool in the market. So this is very important because you can see here that there are tools for anxiety and depression, for symptom monitoring, quality of life improvement, symptoms monitoring, emotional distress, fatigue and quality, not for breast cancer especially, and not for what we're doing, but it exists. And of course, we have a lot of software. This is part of that will be analyzed later. We have also the talk now by Constanza, who will give you a lot of details. And we're aware within the consortium about MDR. We have discussed many times about that. Some of us were more aware about that. We have our experts here to discuss that and give suggestions. But of course, we have software as a medical device. Here is the path. This is a graph that I borrowed from a previous discussion that we had with Professor Malitas, who is with us today, how we can use those, because at the beginning, everybody was asking us, am I starting a clinical study? How can I use this in the clinical study? And we have to present it there and convince our clinical partners that we can perform that. Of course, if we like to see the project as a whole and to see the ambition of what we like to achieve, the first one is to validate and create a new care pathways and healthcare models. Actually, next Tuesday, we have the scientific meeting, and this will be the first question to them, because we have the standard of care that, now in the CARDIOCARE, we have drafted it, and then we have an empty box to show how we can achieve that. New clinical guidelines and best practices, which goes with the first one. And of course, we have to develop modified quality performance indicators for the management of multi-morbidity, and this is ongoing work. Then on the other side, the main outcomes is to create and this is very important, a novel set of biomarkers, the psychomarkers and the intrinsic capacity indicators, which are the markers, that we can use also in the overall impact, to develop new integrated behavioral and psychological interventions. And actually, we have done that. Now we exercise those, and we're trying to understand at which stage we are, to develop the neurostratification models. You have seen a lot of outcomes from that, because this is a very important part of the work. And then to promote the new evidence-based and best practices, which goes with that. And actually, it's the first question, as I mentioned, to the scientific committee that we have on Tuesday. And of course, management, patient-oriented healthcare, which is targeted by the health applications, to optimize healthcare economic costs. This is something that we're carrying a cost-benefit analysis. And finally, to enhance the healthy aging and quality of life, which again comes, to the best practices, the key quality, this part here, and also, to the indicators that we're developing in other, let's say, tasks. So basically, this is the work that we're doing. Of course, we're planning to have a lot of impacts here, but it's not time to discuss where we are now. But as you can see, we're moving, let's say, in 3 different stages. And we have done a lot of this work as we're approaching, to the 4th year of the project. Finally, just a few words for you. It's especially for our external partners, is the consortium. The consortium, is 6 clinical partners, different clinical partners. One in Italy, which is IEO, and Giuseppe Corigliano from their, an oncologist, coordinates that. Then we have EOL from Slovenia. Then we have the National Kapodistrian University of Athens in Athens. We have University of Ioannina, and also we have the Karolinska University Hospital in Sweden, and BOKOK, which is the Center of Excellence for Cancer in Cyprus. We have technical partners. We have IMS, who is a CRO, but responsible for these things that we're discussing here. And of course, we have Streppel, doing all the analysis of the omics data, and the European Society of Cardiology as, let's say, the mechanism to disseminate, to bring to the commission, to the community, to the society. So closing this, I consumed only 5 minutes more. Okay. So that was a very short introduction. I don't know if there will be any more questions when we're discussing, because we'd like to go a little bit further to that. We have to understand where the regulatory issues apply, because today is to a navigation to the regulatory landscape, in this field. Okay, thank you very much.
Thank you very much.
Okay. And I think that now, you will make that, Costanza.
So I don't know if you got the
I was
presentation.
expecting Federica.
No.
Have it.
So Costanza comes from IMS.
No need to be.
Yeah.
on it.
So this one is.
I'm just going to put it just a second.
We start the discussion.
Hi everyone. So my topic was very broad, so I had to give an overview of the regulatory aspects of cardiovascular health. No.
I know.
Okay. So of course, cardiovascular health is a huge area. Cardiovascular disease are one of the major causes of disability, mortality, and loss of quality of life, and of course, public health concerns. So of course, thousands of solutions exist for a diagnosis, treatment, prognosis of cardiovascular diseases. So let's say that the main categories in which such solutions fall are drugs, medical device, and in vitro diagnostics. To the best of our knowledge so far, doesn't exist any solution to predict the risk of cardiotoxicity in patients undergoing treatment for any cancer. Our study specifically focused on breast cancer patients, but in general, we didn't detect any type of any tool that is designed to stratify for the risk of cardiotoxicity due to oncological treatments. As presented before, CARDIOCARE mainly focuses on the development of outcomes that fall into the medical device area and partially into the in vitro diagnostic area. And beside the 3 main categories of main classes of outcomes, there are also some gray areas in this scenario. And for us, the most interesting one is the one related to ml solution, which often don't have a precise classification in terms of validation and applicable regulation. So, as said before, CARDIOCARE mainly produces software. So for us, the most interesting, most relevant part is the definition of software as medical device. And according to ongoing regulations, the software as medical device is defined as any software that is intended to be used as per medical device. The definition of medical device is quite broad according to the medical device regulation, and is basically anything that that has an intended use for one of the specific medical purposes specified in the regulation, which are diagnosis, prevention, monitoring, prediction, prognosis, or treatment to alleviate disease or to compensate an injury or disability. And then there are many more, but I didn't quote all of them because they are not really applicable to our case. As said before, in this case, the applicable regulation is the MDR, which is the regulation 2017-745, and which sets clearly the pathway for the validation. And what is very relevant is the pathway for clinical validation, because it's very time-consuming and can be very expensive. So it's one of the issues of the more critical issues, I would say. In terms of validation of the device, of course, the main areas to be validated are the performance of the device as per intended use, the clinical performance, so if the device achieves the clinical benefits as stated in the technical documentation, and the clinical benefits which are observed during the investigation. Besides that, the CARDIOCARE will also generate a lot of omics data, mainly omics data from DNA, RNA, and metagenomics data. This type of information, of course, duly processed, may give rise to new biomarkers. And the generation of new biomarkers is part of the CARDIOCARE. It will be done within the time frame of the project. But these outcomes might be in the future be part of in vitro diagnostics. This is not really in the time frame, or it will not happen in the time frame of the project, but in the future, it's something that we might need to consider. And in this case, the reference regulation is 2017-746. And also in this case states that the definition of in vitro diagnostic medical device is very broad. And basically it says that an in vitro diagnostic is anything that uses specimen, including blood, tissues, or any other tissue derived from human body for the purpose of providing information on one of the following areas. And we fall in several of these categories potentially. Physiological or pathological process or state, predisposition to a medical condition of disease, if we also consider that cardiotoxicity may be a specific medical condition, to define safety and compatibility of recipients, because the in vitro diagnostic based on the biomarkers developed under CARDIOCARE may provide information that guide the treatment, the oncological treatment. And again, to predict response or reaction again to the treatment. Also in this case, there is a precise step for the validation of the EVT, and it includes prove the scientific validity of the methods, the analytical performance, and the clinical performance. So another topic that is interesting is about ML solution. The definition of ML solution is provided by WHO is very, very high level. So in general, mHealth is anything that uses mobile devices, wireless technology to support objectives of care. So in the landscape of mHealth solution is very complex, and there are thousands of applications around. Some of them are marketed, some are not, some are validated, some are not. And some of them provide medical recommendation, and others self-management, and others simply track some aspects that in any case are related to some extent to the prevention or secondary prevention of cardiovascular diseases. And so it's an area that is very difficult to map. On the contrary, it's the same slide, the same image that was presented before. The area of digital therapeutics is very much more narrow. And in fact, the term digital therapeutic is linked to a different degree of validation of the software and evidence obtained. And all these solutions, for example, are validated, are on the market, have a specific approval in which is the CE mark for Europe, but FDA for the US. So according to the competent regulatory authorities. And part of this digital solution are also reimbursed by the national health system. So it's a completely different level of validation of the technology. And I think that's it from my side. It's a very general overview. If you have any question.
I think that Costanza should I chair now?
Outside?
Should I chair the whole thing, coordinate?
Yes, please.
I think that Costanza presented the overall, concept of what we're looking for. I don't know, from the outside experts, are there any questions up now? Some clarifications. Of course, more would be given, by presentations, technical presentations by Kostas and Manolis later on.
Well, from my side, thanks for the invitation to be part of this meeting. It's really a pleasure to work with you, and whatever Professor Fotiadis is around, if you join, you always learn. So thank you. Really interesting projects. Your challenge is the challenge of many of us in other projects. From what I have seen now, I would not enter the mHealth landscape at all, because the other regulations were legal. There are regulations, there are rules. mHealth it could be whatever. So I wouldn't go further on exploring what does mHealth means unless there is a regulation out there that I need to address. So you pointed out to digital therapeutics, to the medical device. Trying to come up with a new definition of mHealth is kind of, I think it's not gonna work because there are so many. This is my only comment from now. Just because I see other people struggling. What is mHealth? Who cares what is on mHealth? What matters is if it's a medical device. If I'm going through digital therapeutics, then if it's a mobile app, a web application, or a sensor.
And there is a lot of confusion.
That's it. It's impossible to enter this field with. For us, it's always very difficult. So we try to avoid this discussion because it's endless, and I don't know if it's useless.
If I may, first of all, congratulations. It's an excellent job, starting from Professor Fotiadis and all the rest. Very interesting project. Great job, and don't be stressed because of my presence, possibly. The only point that I would like to mention in your presentation would be that in the regulations, they are broad, because the regulations say they are not directives anymore. So if you go through a law a legal document in any country, Italy, Greece, Switzerland, wherever. It's gonna be a single law, could be thousands of pages. So more or less that's the part of either MDR or IVDR. However, 2 points. 1 point for you is that I would like to see and to listen quite significantly the issue of the pharmacogenomics, meaning going towards the companion diagnostics. Companion diagnostics, definitely they are part of the IVDR, definitely is the future. All right, everybody, both sides of the Atlantic, they're working. That's the main interest. The rest is okay, who cares? It's a repeated story. So, and don't be scared to point it out to the rest of the consortium. And why is that? This kind of consortia funded by European Union, they have a luxury, they have an advantage. You can combine clinicians with engineers, bioengineers, etc., etc. So that aspect, when you have a clinician who is prescribing a drug, but on the other hand, you have Professor Fotiades or Professor Tsikakis' team that they are trying to figure out biomarkers, not necessarily from IVD, but it could be from imaging or from ECG analysis. Right. This marker should go along the process of the action of the drug that the clinician is seeing within his patient. It's not necessary, it could be related either to the cardiotoxicity per se, as if I understood well the core subjects of the project, or for the breast cancer disease progression, as it's the main pathological state of the patient per se. To cut a long story short, well done, don't worry, you got the point. And I'm waiting to hear your questions or your comments about my chat. The thing that I would like, with all due respect, to point out, mHealth has come to correct issues that they were misconcepted by the general term of e-health. And in the regulatory field, in the medical legal aspect, we had a great difficulty to characterize and at that point to create a pathway for any kind of innovation. How you develop, how you have, what kind of design output I would accept from a lab, then what kind of verification data would be minimally acceptable in order to go to the validation. Because, all right, if a regulatory guy tell you that, yeah, you can carry on with the validation procedure, right? And then at the end of the day, you have lost 10 million or whatever of an EU project because it couldn't work, because all the verification story is out of the scope. That was the reason, the main reason, to try the regulators to come up with e-health, and there will be more. mHealth, which I fully disagree, because clustering innovation has to be more specific, more claims oriented. And the claim is not only the intended use or the intended purpose of it, but also of the intended use. What I would suggest, I was in a meeting with some European guys here in Brussels a long time ago, and when I proposed them that, okay, you should follow the Indian paradigm, they were really laughing, and I said, yeah, India is not a regulated country, but what they have tried to do is to come up with thousands, endless numbers of solutions. Most of them, they are fake, but at least some of them, they have a point, and they are working, and they are creating not only publications, but they are creating products. That's why half of the Silicon Valley is with Indian guys now. This is what I want to say, is that mHealth has come for a specific purpose. The bureaucrats that they were trying to support it didn't get it. I fully agree with that. And they were trying at some point either to add on things or to correct things, and that created a mess. And we are facing this mess from the WHO perspective in Geneva, that when the guys they are trying to figure out how they can come up with a guidance, right? Guidance document, not even a regulation. It's a mess. It could take years. Sorry for wasting it.
If you allow me to intervene, I think I'm not sure I fully understand the debate and the discussion between e-health and m-health. But from my point of view as an engineer, I think that the distinction is clear and is based on the different type of enabling technologies. E-health was traditionally had internet as an enabler, an enabling technology. M-health on the technology level relates to the use of mobile communications and wearable, et cetera, in developing solutions for patient monitoring to support independent living, et cetera. Now, from the regulatory point of view, I fully understand that there are different requirements and different provisions, and potentially they generate different complexities to address the regulatory landscape. But I mean, conceptually, at least, I think there's a clear distinction regarding the difference between e-health and of course, here in CARDIOCARE, we are talking about m-health solution because, as I'll be talking in a minute, wearable technologies, et cetera, with a specific objective. And the objective, I think, and Dimitris already referred to it in the beginning, is first of all to examine the possibility as to whether additional variables and additional biomarkers can be provided to the overall risk stratification model, which is based on the clinical data and the imaging data, and this hard and accurate data generated in the context of the hospital environment and the healthcare institution, in addition to potentially some data that is not so rigid and fixed and is generated in the patient's own environment, living environment, et cetera. And there are some initial indicators, as Dimitris said, that there is potentially some value there. But I think the most important role of the wearable technologies, in my view, is monitoring disease dynamics, as you referred, monitoring and seeing continuously what is the effect of changes in treatment, what is the effect on the dynamics of the disease, and enabling the continuous monitoring of those dynamics in the living environment.
Okay, let's stop the discussion for that. And now we have to move, to the next speaker, which is, to me, is known as Paco.
Yes.
Okay, but
What is Paco?
as Professor Lucianes Villanova, since Paco, since it's the first time in the group, please say a few words about yourself.
Yes, of course.
Introduce
Indeed.
you.
Yeah, thanks a lot. I think we are going to have fun today. I really want to jump into the discussion again, which is the most important part of the work, having fun. My name is Paco Lupiáñez. I'm a professor at Open University of Catalonia. However, 15 years ago, I decided to combine my part in the academia with some consulting and research. So bringing what we do in academia into consulting, okay? Partially because I'm from the South, and in the South, getting well paid for being a professor is quite difficult. So that's why let's go and be an entrepreneur, okay? I'm a health economist by training, and we work in the interaction between behavioral science, regulatory science, and data science. So we work in these three fields. We are not good at anything. I can already anticipate you. We try to be good at the interaction of fields. So then when I hear someone talking about regulation and technology, I can start discussing. So we work in the interaction of fields, okay? And we work as a multidisciplinary team, really, from physicians to nurses to psychologists or economists within the team, which is super fun, okay? And today, what I would like to talk is about the regulatory framework in the EU, challenge and prospect, focusing on something that is one of the new ones, which is the European data spaces, a new one in the blog. What I have heard and read from the project is that the medical device in vitro, it's more or less clear. There is a need to interpret, there is a need to go through the process. What is the best way to go through this process, depending on the intended purpose, depending on the market. Digital therapeutics is there too. Again, what I would like to point out is the new one, which is starting soon, and it enters or try to regulate the primary use of health data and secondary use, okay? And we will start discussing, I hope in Europe we don't go the Indian way. Maybe yes, and we need to go that way, okay? So very quick around there. For me, COVID proves two things. First, two things in Europe, being a very some kind of provocative. Okay, first, it proves that the application of information and communication technologies into health works. Okay. It could be more or less cost effective. In the case of pandemic, it was super cost effective because otherwise there were no cases, okay? But it works. And the other thing that it proves is that we are able to collaborate. I mean, if you think that 27 member states agree to have a COVID passport in a few months, when we were discussing 15 years of interoperability, and all of a sudden, boom, it works. Here we go. We can exchange this information. And this has boosted everything. Even now, the Germans are saying that they are digital champions when they have never done anything in e-health. Quotes and quotes, I'm sorry for the Germans. But before, they were not champions on the e-health. Now, all of a sudden, yeah, we want to lead the market, and we start paying for that. Okay? However, when you see the indicators of the deployment of electronic health record, or other indicators, the Germans were not there. Now it seems that they are leading the market, quotes unquote, or the French. Again, they are leading the European health data spaces. Have you heard from the French 10 years ago doing something on digital health? So something is moving at the EU level. And this something also, the Commission, the previous one, is difficult to talk about the landscape when we have a new European Parliament coming. Let's see what happens. The previous one set up this digital decade where they say, look, we need to push because it has been proved that digital is important, so to speak. And then they start launching the regulations, okay? A few ones, some of them are more relevant, others are not that relevant for the healthcare, but I think it's important that we understand that it's not just one, there are several. So the Digital Service Act to foster innovation, growth, and competitiveness with the SME and startup. The Data Governance Act, we don't talk about this one. And this one is really important because it's the basis of the European health data spaces, quote unquote. Cross-sectoral instrument that aims to regulate the reuse of publicly held protected data, and the Artificial Intelligence Act. Still to see how this goes into the medical device, software as a medical device. I mean, it seems that it's clear, it's a risk-based, so whenever there is risk, go into the medical device, but maybe there is some discussions now about how this AI entered into the medical device as a software, and how, this can go through a conformity assessment. So there are a lot of technical regulations within technical discussions in the medical device regulation on how this can be done. Another one that I would like to talk about, which is the European health data space. Okay, why I think it's relevant? Because I think there is a great asset. I mean, this regulation is linked to data sovereignty, And it's the first data space that the European Commission launched on health. They didn't launch in automotive, they didn't launch on mobility, they said health. Probably because in Europe, we have the most, or the most comprehensive digital data sets in the world. We can say, no, it's the US. Yeah, US maybe in one specific hospital, in one specific a small region, or in Europe, there are countries and regions digitalizing information for many, many years. And this is an asset for the Europeans. So they launched this, okay? This regulates the primary use and the secondary use, okay? I will focus on the secondary, but I will strongly recommend you to take a look at the primary use. Why? This is what the primary use and the secondary use. Why? Because I think, and again, personal opinion, I'm not sure the ecosystem of digital therapeutics targeting a specific thing on a specific illness on a specific moment on time, it's sustainable. Because if we move into the personalized medicine and drugs are starting to cost 1 million, and the society cannot pay, we will need to reach a new agreement as a society, most likely, because demand and supply needs to talk, okay? And this is where the digital companions, all the tools in relation with the medication may emerge, okay? Maybe these tools are not sustainable if we do isolated tools. And this is why the primary use is important. This is trying to set up the rules to play with data on the health system, at the health system level. What type of rules? Interoperability is going to be compulsory. And it has implications, because if I develop a digital biomarker at a certain point, I don't care about the app. Because most likely the formula, the algorithm, the guidelines is gonna be implemented in another app. Why? Because as a health system, I cannot afford integrating 300 apps per provider. So maybe I put the pipeline, no? It's like we need to start thinking about platforms and not applications. And I don't know how it will evolve, because I'm not a magician. I'm still, despite working in consulting, I'm still solid on the ground and of science. I'm not sure if the systems can pay for singles applications. What I'm sure is that this regulation is trying to set up an ecosystem, an order for all these services or products to be interconnected. So the integration of these into the system, the cost of integration decrease. Now we all know when you have a wonderful app, a wonderful system, whatever, the cost of integration into the hospital is higher than the value that it brings. So what this is trying to set up is the rules for the primary use and secondary use for supply and demand. So the electronic health record providers will most likely go through conformity assessment to prove that their products are interoperable. Okay, and again, this has implications for all these type of projects, because maybe we are not selling an app, we are selling the formula, and the formula will be implemented in a third-party app, or not. But I don't know if you get my point. Where I'm coming is if the rule is that the information should be interoperable, the infrastructure should be like the highways, like, hey, this is the health system data highway, quotes unquote. You can connect it. Maybe it's not a question of having, like 5 years ago, there was everybody was talking about the marketplace. Every European project was developing, I develop a marketplace for this, a marketplace for that. Look, marketplace, there are 3, Amazon, Google, and Apple. Don't even try. Anyway, I will not touch this, but I think this one, it's important that you take a look, that you read it, because you can get some hints on whether at the end of the project you will have a product, or you will have a formula that could be integrated in third-party products. Because I cannot afford reaching the market, but I can afford partnering with a third party to integrate my best, the guidelines of the evidence into something that is currently out there. I don't know how familiar you are with the European Health Data Spaces. Are you familiar? Have you heard about it? Yes, more or less. So this is the infrastructure they are proposing. There will be a central node, okay, at the European Commission level. Then there will be health data access bodies across Europe. There is one per country that has the representation with Europe, but then in each country there could be more than one. Okay, imagine the countries where they have a decentralized or regional healthcare provision. There will be one central contacting with them, national contact point, but then in Spain, for example, it could be 17, as many health data access bodies as regions, okay? That will be the data users, the ones who can use the data holders that is linked to the GDPR and who not owns, because the data, I think is not, but by legal term means not owned, but who holds the data. In some cases, they're the regions, in other cases, they're the hospitals. The data holders normally are not the patients. Okay, this is important. And then the data governance act, and then these people can charge fees to share the data, and these people can access to this data. This is how it will work. So you, as a data user, you will have an application, go to the health data access body, evaluate the application. They need to be transparent. They go to the data holder, please give me this data, anonymize or pseudo-anonymize, and then you need to publish the results. This is a very simple diagram of how it will work. All of this by saying that the data, anonymous or not anonymous, is going to be an asset. And again, the data that you are producing into the project, it could be an asset that it has value. Why? Because it's high quality data that could be linked to have something else and add more value into that. However, it may need to be public, and you need to assess whether, because you are working on with the health system, by default this data is someone will have the right to get access to this data. And this is now starting. Another important thing is it's supposed to be, it is said that in November this year it will start, and member states will have 2 years to implement this, okay? So we are starting now, and this is an opportunity. I mean, when the GDPR, I think it was 8 years since it was published until it was up and running. We are starting now this run in November. So again, projects like this could start working under the new assumption of the new the proposed regulation in order to be front runners on new business model, new ways of making things sustainable that are beyond I'm selling an app, I'm selling a mobile app. And this is how the Commission, oops. Okay, this one. Well, this one, there was an issue. This one has, this is how the Commission is painting the journey, okay? Is there a data set catalog that support my research? Yes or no? Can I use this data for my research project? Common data access application. The health data access body will issue a permit. They will give access to secure processing environment. I analyze the data and publish the results. Again, in addition to the medical device regulation and the in vitro regulation, where you have a clear target, you may start thinking about how this data could be part of something that has value and that could contribute. Okay, I guess your data alone has some value. Your data integrated with other data will have more value. And this could be, let's say, the sustainability plan around this. It could be different than just an app. Okay? This is how it looks like. This is by the European Commission. There will be a portal, institutions, the data sharing infrastructure, data access bodies, and how this will be circulated. If we are talking about digital biomarkers and we are talking about digital therapeutics, the data that you will generate in something that in other projects we are starting to call behavioral medicine, it has a lot of it has a lot of value. Why? Because normally you collect clinical data, but you do not collect behavioral data. And if we know that the genes is 20% and the rest is 70% is environment and my behavior, if projects like this start combining the clinical data with the behavioral psychological data, you may anticipate behaviors. So you may support better the new treatments, okay? And there is a value. I mean, it's not by coincidence that we have the Apple Watch and they have some medical device algorithms within the mobile. Okay, they are capturing our behaviors that they will be useful for something and they will monetize somehow. So maybe through the type of applications that you are doing, you could start collecting this behavioral data that it's part of behavioral medicine and complement the clinical data. And again, and we were in another project working together. If you go to SNOMED CT, check and find something about behavioral data, behavioral medicine. Check it. No, behavior is very important. Prevention is very important. Yeah, you go to the clinics and see. So projects like this may start building the common data models to start capturing behavioral data that is supposed to be important in medicine. Okay, so beyond the intended purpose, and here we start talking about the boundaries. There is an additional added value on the data that you are capturing beyond the intended purpose that you may need to include in the intended purpose in order to collect this data that could be useful. But there is where there are nuances on the how we call it. I don't want to spend more time or the data users, okay? If you are gonna be a data user or your clients may be data users of the information you are collected, think about their needs. You know what I mean? Anyway.
But
Anyway.
I know what you mean, but
Yes. So what I'm basically suggesting that the regulation collects what is each of these actors, what are their responsibilities, okay? So then we may need to start reflecting on how this new regulation is setting a new ecosystem, it's setting a market, basically. Okay, till now, it's not recorded, the session, no? Or yes?
Yes.
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 It's recorded, okay. And we have to be careful of what we say. Till now, the health health data market is a monopoly. You have the monopoly of the big three, no? IQVIA and the others. Huge market, a monopoly. The mini monopolies of doctors and healthcare institutions. This is my data because I have worked very hard on this, but they are all monopolies, okay? This regulation, what it's trying to set up is, look, let's try to build ecosystems. Let's try to regulate how we can use and play with the health data, respecting the fundamental rights, but trying to develop some innovations with some certain rules, okay? So there are gonna be data users that will have needs. Okay, this digital biomarket, the result of your application will fit someone needs in a data ecosystem. And this could be another way of making sustainable the product, not just with the product itself or with the service itself, but with the data that we are generating. The health data access body, the same. These are the ones that will regulate the access. You can access, you cannot access, but it's gonna be transparent. Till now is who you are, this, where do you come from, this. Do you know this and this? Yes, okay, I give you access. Who you are, this, no, you don't have access. Yeah, but legally speaking, I can because it's anonymized data. No, you cannot have access. Why? Because I say so. So what we are saying is there's gonna be a health data access body who will set up the rules. who can have access, under which conditions, and which is the process. And then the purpose of use. It's the regulation clearly identify what is the purpose of use of, for what purpose the data can be used. And again, when you are generating data with your innovation, with your application, you may need to think about this type of purpose, because this could be the generation of something else, okay? And it's difficult because the medical device regulation is telling you a clear intended purpose. The GDPR is telling you a clinical, a very clear aim for data collection. Well, you may need to be to be creative in the way you phrase your intended purpose in order to comply with the medical device regulation at the same time that with the GDPR, and at the same time with this new one, because this new one, it could offer you a spillover effect of your data, because by using in another layer the data you are capturing, you may be getting additional sustainability pathways. This is about the data holders, and again, the data holders will have to make available the data following some rules. And here I would like to emphasize the importance of the standards. I know that we are all familiar with the standards, but I think now and I'm not sure the status of this in your projects. In other projects we are working on, when we work for the Commission, we start making emphasis on data models, not just in interoperability, because interoperability is just one point of the equation. If you talk about semantic interoperability, yes. So what we are trying to do is to set up interoperability from minute one, from scratch. How? Using common data models. Otherwise, it's too late. When we go to the data integration and in the interoperability, it's too late. So we are putting emphasis on, it's work on data models, common data models, transparent data models. I don't care what is the flow, just tell me the meaning of the data from scratch on a data model. And this could help you to integrate your application in the future through the primary use of data. Why? Because the primary use of data, it's signaling, hey, interoperability, but at semantic level, maybe you need to get to work on standards on the data model, not on the technical layer, but on the data layer. So when we say from regulation to practice, if we or you will be targeting a new ecosystem, a new market in relation to data, the primary use, for the clinicians that use their data, or the healthcare professionals that will use your application, but also for secondary use, because the data that you will generate could be useful for a larger community and could have value for a larger community. It's important that you start, quote unquote, reflecting about the value of your data for primary use and for secondary use, and data users, health data access bodies, and the data holders, what are their needs? What is the governance that they will establish across their data? What are the services? Again, you can sell your app, or you can sell the AI, and then the AI or the algorithms can be integrated in a third-party app, or can be integrated in the short term with the primary use of data. European electronic health records will need to be interoperable by default. Therefore, adding services to this electronic health record, it would be possible. The cost, it would decrease. So what type of services you can integrate in this new pipeline that is coming, and what is the sustainability plan? Okay, just is an app enough, or we need to reflect on that the regulation, the new regulation, the forthcoming regulation, could enable new business models or new sustainability plans that now are not in place in relation to the primary use of data and the secondary use of data. So the final message is we may understand, and this is counterintuitive maybe, and I'm happy to discuss afterward, we may understand regulation as an enabler. Okay, it's an oxymoron, it's impossible, no? But because the rules are given, we can vote, but the regulations are given. What if we take advantage of how we interpret this regulation? Because as you were saying, they are not go left or right. They are, well, go left, but the road is like this, okay? So interpreting. So if you interpret the regulation in a way that is obviously being compliant, it may give you opportunities. And you are at the right moment. Why? Because the regulation is starting now. But you could be launching the right questions to the right people and helping them to do things. Thank you very much.
Paco, thank you very much. Just to go to the other two lectures that we had before the break, there is coffee outside served. So if you like to have 2 minutes just to grab your coffee, it's okay. And then to have Costas to start, the imaging. I'll get it. So just for 2 minutes, 2-3 minutes.
Ok.
Quindi può associare una faccia.
Sì.
Infatti
questo sentato al nome non lo faccio. Comunque, meglio che niente.
Sì, no, la spiego.
Tocca almeno.
Sì, perché in realtà mi sembrava che una soluzione al dibattito di cui si diceva prima, oggettivamente, perché una volta che...
D'altronde alcune definizioni che presentano la professoressa Conte sono le stesse che abbiamo adottato nella scrittura.
Esattamente. Sentendo il dibattito, poi io non avendo un background medico effettivamente, però effettivamente se la spera quella cosa c'è da scegliere.
E questo Okay, so I will be starting in the sake of time. I'm Costas Marias from Fourth. I'm afraid my talk is not so provocative as Paco's, so sorry for that. It's more technical. I will be talking about a specific part of what Dimitris Fortiadis presented in CARDIOCARE, the whole vision, and focus more on risk models of cardiotoxicity based on imaging data. So it is one task, one component of a project that we thought that it would be interesting to share with you in this meeting. Okay, so I need to find the right button. I'm going to go to the next slide.
Try now. Does it work?
Sorry, I'm stuck in the first slide, so.
Try again.
Okay, maybe you can.
There is some.
It's working.
Okay, perfect. Okay, so thanks to all my colleagues, Grigoris, Giorgos Manikis, Giorgos Kaletakis, and of course, Dimitris Fotiadis, Yuria Karanasiou, Manloris Ignakis, the fourth team who is working on this very provocative and, let's say, innovative project. So we'll go straight away to some, let's say, background information about, let's say, why we want to model cardiotoxicity. First of all, it is a very common, let's say, side effect of chemotherapy, and not only of chemotherapy. If you look in the literature, in most of therapies used in oncology, cardiotoxicity may be a side effect, even in targeted therapies, immune therapies, so on and so forth. So it's becoming a big problem. And one important, let's say, rationale for this work is that despite that we know about this problem for decades, there is still no optimal, let's say, standardized way to detect. And of course, while there are many guidelines about which provides recommendations, we don't have at this moment the standard, let's say, framework for screening, detecting, and let's say doing the optimal strategy, developing the optimal strategy for cardiotoxicity detection and therapy. Of course, with new treatments and with new remedies for cardiotoxicity, all this project that Dimitris presented is becoming more and more critical. There is, of course, AI in the picture, and I would say that nowadays, whenever we have the idea of screening, you will see that AI is becoming more and more, let's say, an integral part of screening. We see that in digital mammography, that now in Sweden, AI systems are going through randomized clinical trials. In the future, you will see it with lung cancer screening. AI will be an integrative part of it. And of course, we believe that also in cardiotoxicity, AI can play an important role. Of course, we have imaging, which is routinely based. Especially echocardiography is not expensive as other imaging techniques. It does not involve ionizing radiation, which is very good for, especially for patients. But it has some weaknesses, right? For example, the left ventricular ejection fraction on its own is not a good biomarker. Of course, we have GLS, strain imaging, which is more advanced and becoming now an integral part of the assessment of these patients with imaging, but still it has weaknesses. And in many parts of the world, like you see here in this China, there are similar efforts with CARDIOCARE that understand that a lot of drugs are producing potentially toxicity in the heart. There are different degrees of toxicity from systolic dysfunction in the left ventricle, congestive heart failures, arrhythmias, and so on and so forth. What is important here as well, you see that also in this paper, they understand the necessity to look into biomarkers from different levels and different imaging modalities, different signals like ECG. Of course, in CARDIOCARE, we're doing much more than that. And what we want to achieve, of course, there are recommendations, and the European Society of Cardiology has issued recommendations for cardiotoxicity, even in the COVID period, which was a very difficult period to monitor cancer patients. We know from, of course, our clinicians that we collaborate, COVID was a very challenging period for cancer patients who could not go to the hospital. And we believe and we support the idea that AI modeling can enhance the current state of the art and give more power to models that could predict earlier cardiotoxicity in cancer patients. So risk stratification on imaging data is a task in the project. So we have a whole modeling for package. And we're trying to extract information from imaging. So we're not doing miracles. AI is not, let's say, it does not generate miracles. It takes measurements of shape characteristics, texture characteristics of the image, and it's doing a much more exhaustive, let's say, analysis than humans can perform, develop models. The idea here is that in this project, as we develop it with the help of Dimitris, we are thinking about cardiotoxicity as a forecasting event. So we're not trying to have like a binary outcome. It's going to happen, it's not going to happen. We're trying to predict how likely it is to happen in the next 2 or 3 months. And actually 3 months is kind of is the interval that we have now for our data. So it makes sense to try to predict in that specific interval. So of course, we are going to develop models to see if we could predict a year ahead and even more. But for the time being, we're trying to predict from baseline to 3 months based on echocardiography. I don't know why this is shaking or... Okay, so we are doing a very exhaustive data collection on imaging. So we have set specific, let's say, requirements to the clinicians so that our data is more coherent. Of course, we are working on 2D data, but AI is very flexible. If we had 3D, it would be even better, because the contraction of the heart is much better quantified and understood in 3D than 2D. And GLS is exactly doing that. It's trying to quantify the strain of the heart. And we have some annotations on the frames, if it's end-systolic and diastolic, so on and so forth. We also have the measurements that the clinicians are providing, the ejection fraction and the GLS. And we're trying in different time points to gather this data. It's a very innovative project, so it's been quite hard, especially for Dimitris, to harmonize all the data across different centers. And that's what we said before, that echocardiography is not particularly homogeneous techniques, like, for example, computed tomography. So now for some patients, we have reached up to the 12th month, which is very good. But for most patients, we have data for 3 months, and that's what we are kind of experimenting at this time point. So we have the baseline, and we also have the ejection fraction and the GLS. And then we're trying to predict in 3 months if a patient will develop cardiotoxicity or not. And we have two approaches. The one is feature extraction based, which was also Dimitris showed before. So we know that the damage is going to happen in the myocardium, in the left ventricle. So we're trying to segment, of course, that specific area of the image. We don't want to look into other areas, because that's where we want to focus. And we have developed segmentation algorithms that is computing this area. We're tracking changes in this area between these two different time points. And we're looking at these delta features before and after to detect changes. And the idea is to integrate it also with other semantic features. Like, for example, we might have some arterial calcifications from mammography that also can tell part of the story. And of course, all these features, we need to be harmonized between different centers. There are many techniques to do that, like combat, for example. And then we do feature reduction, and we develop several machine learning techniques. And last but not least, which is now becoming an integral part, we're trying to develop explainability components, which means we would tell a cardiologist why we believe this is going to happen based on specific features of the model, not just being a black box that is telling the future. So now we are at the point that we're looking at several features in these 3 months are changing significantly. And we have not developed a model yet, but you can see here that there are quite a few features that they have significantly different p-values before and after these 3 months, while other features remain constant. So this kind of is quite encouraging, because I think it shows that we are focusing on the region that changes happen during these 3 months after therapy and after the administration of chemotherapy. And of course, we have other techniques that are more, let's say, black box techniques like deep learning. We need more data to get results from these approaches. The more AI is becoming, let's say, invariant, is becoming, let's say, sophisticated and not requiring data preprocessing, the more data you need to overcome a lot of problems that are associated with that. So we are developing models from scratch. We are transferring models from real-world images like ImageNet. But we believe that an intermediate approach that we're doing now is to get a data set from cardiology, from the same domain, and try to set thresholds. For example, put a threshold between pathological and normal left ventricular ejection fraction, and try to get these weights. So far, this looks quite encouraging. Looks like these models can understand, without any human intervention or without any feature extraction, can understand when a specific echo is beyond or below 45% threshold or being characterized as pathological or normal. So we can use these weights to get an edge in CardioCare and then with our own data to improve it further. And I think it's better to use cardiology data instead of real-world data, although now we are moving at a world that believes that we can have models for everything, as they call it, foundation models. Still, we think that results tell that this might work better. So of course, once we gather all the data from the next time points, we will also see what is the best performance in terms of prediction. So can we predict from baseline after 6 months, or is it better to wait until month 3 and then predict for the next 6 months? So having all this data will give us also many experimentation, let's say, possibilities to see which are the safest and more precise and more trustworthy ways to predict future events of cardiotoxicity. And of course, the reason we want to do that is to have a better, let's say, patient outcome than we have today. Because when you use a weak biomarker, which, for example, the ejection fraction, if you see problems in the ejection fraction, it means that already a lot of damage has happened. So you want something better, and that's where all this comes to the picture. Of course, as Dimitri said, the future of AI, the future of modeling is integrative. We want to put as many things together from different scales and from different, let's say, aspects. Different scales, meaning, for example, metabolomics, genomics, and different aspects, different, let's say, viewpoints like behavioral or, let's say, biosignal. And also the time resolution is different. If you wear a band, you have data every second, right? Or every minute. An echo, you can do it every 3 months. It's not practical to do it every day. So all this, we hope and we believe strongly that can be integrated into other models. Of course, depending on data, you cannot always claim that you're going to have this data, but you can build nomograms depending on which data you had, the wearables and metabolomics imaging. And we hope that we could propose nomograms that will allow cardiologists to detect cardiotoxicity as early as possible. So that was from my side. I hope I didn't take much more than the time that I was supposed to. And thank you very much.
You understand from the presentations of Kostas that what we're trying to do with the investigation, let's say, of digital biomarkers or radiomics features in the prediction of cardiotoxicity, that we're trying to go farther from what today is used, okay, and to see if those biomarkers can be used for more accurate predictions or jointly with other, let's say, features can produce something on the detection and monitoring. This is why we're doing that work. It's a substantial part of our work. And finally, Kostas and the others should integrate those in one risk stratification model. So it's towards the risk stratification. So let's go to the next presentation. Manolis, again, 10 minutes.
Thank you. As always, like Dimitris, I tend to take more than the time allocated, so keep me on track. Thank you. I was asked to, can you move on to the next? Okay, so I was asked to focus on the role of wearables and biosignals in AI model development, which is a general topic, but with a focus on CardioCare projects. So basically, I'll spend the next few minutes in describing what CardioCare is doing in the area of wearables and AI model development, and what are the initial results that we've achieved so far. Again, many thanks to our collaborators from the Mediterranean University, Hellenic Mediterranean University, where I'm a professor of biomedical informatics, but also the computational biomedicine lab at Forth, where together with Kostas, we're affiliated professors and run the relative lab in there. Now, what is the objective? The objective in this activity is basically, as we describe in our description of action, to enrich the variable study. Most of them were already presented by Kostas, for developing an integrative risk stratification model for cardiotoxicity with information from wearable sensors and mobile health application data sources. Basically, we see those, as we've already discussed, to the integration of wearables and information from mHealth applications, having a dual objective, the one I've already described, enlarge, enhance, and enrich the integrative AI-based model with additional variables that come. But in addition to that, monitor the patient response and the dynamics of the patient response in relation to the behavioral, psychological interventions that have taken place and what those interventions have as an impact in what we call intrinsic capacity and quality of life. So basically, the conceptual view of the work is that we use a limited number of wearable devices, specifically a polar wearable belt, a smartphone. We use a device to monitor the strength, a hand grip, and a range of mHealth applications that capture specific data to a number of questionnaires that I will, and patient-reported outcomes that we'll describe in a minute. And the objective here is to use this data to ultimately, in the end, estimate intrinsic capacity and quality of life and the effect that modifications and the therapy and the plan have on those two constructs. So we started by trying to define what quality of life is and intrinsic capacity is, how it is defined, and basically, obviously, you go to the World Health Organization, who a number of years ago has provided specific definitions for this. Intrinsic capacity, first of all, is the composite of all the physical and mental capabilities that an individual can utilize at any point in their lifetime. Wow, a very wide definition. And again, quality of life, it's a perception of their position in life in the context of culture and value systems that a patient is working. So, yes, those are the definitions. The next question that we're trying to answer is, well, how do we measure those constructs? And again, going after a thorough and elaborate and systematic, in some cases, review of the literature, we see that there are, again, proposals by WHO for how to assess the quality of life. The initial proposal is that the quality of life is a construct that is evaluated in a number of dimensions that span physical, psychological, level of independence, etc. So 6 domain scores in 24 specific facets that include a number of dimensions, pain and discomfort, for example, energy and fatigue, sleep and rest, sensory functions regarding the physical domain, and then equally, when one moves into the psychological domain, positive feelings, self-esteem, negative feelings, so mostly into the psychological domain, etc. And there are defined algorithmic approaches of how to estimate the scores in those categories. Moving on, it was a very complex model, let's say, to assess that. Then a briefer proposal was subsequently produced, again by WHO, but also other researchers. So again, we see the quality of life is evaluated in a 4-domain, but again with a number of constructs and independent variables that relate to activities of daily living, mobility, pain and discomfort, sleep, energy consumption, negative and positive feelings, etc., etc. And more recently, at the European setting, a similar proposal in relation to the previous provided by WHO, again, provides the vehicle for the estimation of the quality of life based on a number of independent variables that relate to all these physical and psychological dimensions of the life of an individual. Equally, intrinsic capacity very recently has been defined as a construct to include or be estimated using 5 independent domains that include locomotor, cognitive, sensory, and psychological capabilities. So basically, then our task in the relevant work relates to answering the following question. We have a limited number of wearables through which we measure some dimensions that are required for the estimation and the calculation of quality of life and intrinsic capacity. And our objective is to, and I'll say a few words in the subsequent slides, to develop models, analytical and data-driven models, to use the data that we have and provide accurate enough estimations of quality of life and its evolution and change in the course of the disease. In parallel, we use mobile apps, and these are the mobile apps to actually provide us with the subjective information of the patient. So we have a number of validated questionnaires in our clinical study protocol to assess resilience, impact of event scale regarding, the psychological reaction of a patient to a critical, to post-traumatic event, to assess anxiety and depression, to assess stress, perceived social support, the affective state of an individual, to assess the range of fatigue that they feel, and specific, again, validated questionnaires, OTC, for example, the specific questionnaires, which provides an accurate enough subjective assessment of the quality of life that the individual is in and their satisfaction with life in general. So we have all these apps, and you understand the challenge for the study protocol and for the clinical centers to actually convince and have the patients with their disease and the management of the challenge of handling the management of the disease, but also having to regularly fulfill 16 very challenging questionnaires that are important at the same time for us in order to assess a number of dimensions and take them into consideration when we move on in developing models based on the additional information that wearables provide us. So we developed a kind of an overall framework, as Dimitri said, where we start with information from these 3 wearable devices that the study protocol defines how they're used every 3 months, continuously monitoring daily, once in a week. They used to record a specific time interval of ECG information. And we initially, through close collaboration with our cardiologists, we defined specific abnormal events that they would like to be notified and made aware of. Arrhythmias, sudden supraventricular contractions, atrial fibrillation, ischemic events are important in assessing cardiotoxicity in the continuous monitoring of the patient's life. And then in addition, using the information that we obtain from a smart wearable watch, we developed a methodological approach to assess a number of measures that are relevant and important in assessing quality of life and intrinsic capacity, as I said earlier on. Frailty, physical activity patterns, psycho-emotional status, stress, anxiety, depression, etc., positive and negative effects, so that at the end, we develop models to provide the information, either the model, the integrative model with additional information that they may consider taking into consideration, but also to provide independent indicators about quality of life and intrinsic capacity of the patient to the treating physician for them to take into consideration in their therapy plan. Again, in doing so, and at this point, I would like to say that we are not working with retrospective data. We're only working because obviously we depend on wearables, so only on the information once patients are recruited to the study. So currently our data is limited, but we developed based again on what information and models and methodological approaches are available in the literature, ways through which we will attack the estimation of frailty assessment, taking into consideration sleep parameters, time in bed, total sleep time, sleep onset, light latency, physical activity patterns, and other such information that we can obtain from the wearable that we have in our hands. And we developed an overall model, again, through elaborate bibliographic assessment that shows that physical activity patterns, sleep quality, and hand grip strength are the parameters mostly taken into consideration into developing models, data-driven AI-based models, which we currently have initial versions of this showing promising responses, but of course we expect additional data from partners, from patients, as patients are recruited into the clinical study to enhance the accuracy of the model regarding the estimation of frailty. Equally, again, analysis of the bibliography shows that psychocognitive models regarding the assessment and the estimation of stress and anxiety depend in 57% of the available 21 studies take into consideration ECG-related features such as heart rate, variability, interbeat interval, etc., etc. So this is data that we have from the belt. Physical activity data in 43% of the studies analyzed, they take physical activity into consideration, including step counts and related information available. We do not have calories consumed, but we approach it, and we have information regarding sleep data. So again, we have a range of variables that we can extract from the wearables in our hands so that accurate, and we are assessing the accuracy of the models that we develop based on objective data with the baseline, the subjective opinion of the patient regarding their status. As I said already, we have questionnaires which they themselves assess their anxiety, their stress, their positive and negative affective state, etc., etc. So our objective, and we are not there yet, is to use all these intermediary models, both regarding the physical status of the patient as well as the psychological and emotional status, into providing a model that will in line again with published relevant work that will provide a specific and accurate enough estimation of the quality of life of the patient and how this quality of life changes or how does it correlate to the disease management that the patient is undergoing with. And at the same time, I said that ECG and the detection of abnormalities in the ECG is believed to be important. That's what the cardiologists, the cardiology experts in the project indicated to us. So again, we employ data-driven and machine learning as well as supervised approaches for the detection of these abnormal events and provide early feedback mechanisms to the treating physicians through the use of wearables. In this domain, a number of time domain features are used in developing supervised in the time domain and feature frequency domain characteristics of the ECG are employed in developing accurate enough, although the data set that we're currently working is only limited, 20 patients, and the objective is to reach 750. So we expect to provide tools and models that are significantly much more accurate as our initial models, but again, these reach a very high performance. And as Dimitris already showed, again, working with a limited number of data from the wearables and utilizing activity and sleep quality information as extracted from the information that is provided by the data in the smartwatch, we can get a good enough approximation of the quality of life of the patient, because we see distinct clustering of those who have a more active day lifestyle and a better sleeping quality, which indicates a better quality of life overall, contrary to those that are having issues in relation to their daily activity. They live a more sedentary lifestyle, etc., and their quality of life seems to be distinctly different to those with a different lifestyle. So basically, what I'm trying to say is that, and we have a plan, of course, in how to complete this work, which in some cases, in many cases, is in our view very innovative. But I mean, my main conclusion for this meeting is that the wearable technologies enable, in our view, as I've already said, to monitor the dynamics of the disease on a continuous base in the normal working environment, living environment of the individual, And therefore, it generates a window of opportunity for the clinical teams, for the clinical professionals, to intervene in a more effective and more timely manner in better managing and adapting disease therapy and the management of the disease, hopefully to avoid additional adverse events, et cetera, et cetera. So I indicated a number of individual variables that Kostas and the team that is working in developing the integrative predictive model could take into consideration, which stem from the analysis of a number of information channels that wearable devices provide. But fundamentally, our work in this specific task will provide, as I said, an accurate enough way to model how the patient responds to the treatment, how the dynamics of the disease evolve over time, which will allow the medical professionals to potentially and hopefully better intervene to more effectively manage the disease. That's all I wanted to say. I hope I'm in time. I ran to stay in time. Hopefully I managed. Thank you very much.
Thank you very much. This is the part of the wearables that we're using for two reasons. One is monitoring. Okay. Basically, we monitor the intrinsic capacity and the quality of life of the patients. And the second, because we're using, some intervention, okay, we like to, and this intervention is basically intervention, behavioral intervention. We like to evaluate the effect. So this part is very, very critical on how we're doing the monitoring, and then we're doing the intervention evaluation. So you understand why we're using the wearables now. And I think that from this part also, okay, somehow, if you are using for monitoring or evaluation of interventions, we're going directly to the medical device, using off-the-shelf devices that we have selected. For clarification reasons, apart from the polar device, I think, all the other devices are not medically compliant. They're not MDD or MDR medical devices. And we have done that because we like to illustrate how choosing off-the-shelf cheap solutions, you can implement that. Otherwise, if you like to buy a wristband, we have in our labs wristbands like the Hepatica one, which is 5 times the price of the wearable that we're using here. So this is also an experiment, and we have to see what else we have to do in order to bring that.
Yeah, but I think, Dimitris, the important with respect to the wearable and regulatory issues, the important difference is that we are not using the wearables for medical decision support. We're using wearables to extract information, to let them know with information that we observe and let them decide. So it's not a decision support per se.
You will hear Petros later on that if we have an acquisition device, gets the information, okay, this is part of the decision that we are making later. So it's a very, very complicated decision.
In which format are you receiving the data? I mean, the data from the company.
For the belt, it's the raw format. It's raw ECG, so the post-processing is in our hand. The smartwatch, yes, has in some cases embedded algorithms that provide us, for example, the quality of sleep or sleep parameters are calculated by so they're obscure to us. So that's an issue, I understand, obviously. So in the sense that we depend on the algorithms of the provider of these.
Great.
Something. How do you plan to disentangle the evaluation of the prediction from the evaluation of the intervention? Are you doing both, right? You are, look, I'm predicting this, and therefore I need to prove that my prediction was right. I guess, and at the same.
Not prediction. Prediction is something that means in the future.
Yes.
Here is not doing any prediction.
What we are doing is we have 16 questionnaires filled by the patient on the regular time points, and we have wearables continuously registering some information which we use to develop models against the subjective opinion and evaluate the accuracy of the models with respect to what the patient himself in the patient-reported outcomes and questionnaires reports regarding his psychological status, anxiety, stress, activity patterns, etc., etc. So we evaluate the accuracy of the models against the baseline, which is the subjective opinion of the patient herself, and then we provide this information to the clinician and let him assess whether the plan, the therapy, the modification, the interventions, in their view, have an effect or not. We do not automatically assess the effect of the intervention on the patient himself. We simply provide indications based on the information from the wearables regarding specific variables. And for example, if we see that the strength increases, if we see that the hand grip and the physical capacity of the patient is deteriorating, that is information to the clinician for him to assess whether the therapy plan and the psychological and other guidelines that they provided to the patient.
Making a decision about the quality of life. But you are making a decision.
We are estimating the overall quality of life of a patient.
Decision.
It's not this. It's an estimation.
But
it's not a decision for the patient for treatment.
No, but
it's a decision.
It's a decision. Yeah.
Sorry, but please.
No, it's a. I mean, but but maybe we can talk during lunch. But I don't I mean, you are collecting information, quotes and quotes, on behaviors from the sensors, objective information, and then you are comparing this with a set of questionnaires, established questionnaires and scales.
True.
Okay.
Not to have a treatment.
And then you this information from the sensors together with this information from the official scales, you show it to the ACP, to the cardiologist.
Yes.
Correct. Okay. So then what you are trying to, as far as I understood, you are trying to set up whether in the future you could substitute the burden of 64 questions
with accurate estimations of the
you are doing a prediction.
It's not prediction.
Association. Or
Association.
Association.
Prediction is for the future.
Yeah, trying to prove whether
time that you have the questionnaires, you replace the questionnaires with a more.
Yeah, the current mode of operation is that the patients have to fill questionnaires validated in order for the clinician to have an idea and assess what is happening to the patient. And what we're trying to do is to develop models with the baseline, the information that the patient herself provides through the question, through the validated instruments, which are the questionnaires, and show that the models provide accurate enough information in a much easier setting by wearing a smartwatch once every 3 months using a hand grip, and every now and then wearing a belt that registers ECG and prove that the models are as accurate as if, the patient has to feel, which are very laborious and time-taking and
So you're doing, let's say, biometric categorization, and that could replace what is the
Exactly,
current state of the art,
Exactly.
and then it will become
If the models
an intervention.
Exactly. It could become once the models are validated, and then they'll have, in my understanding, enter the regulatory process with whatever they implies. Just as we say, the questionnaire have been validated, and therefore now they are clinically acceptable by the regulatory bodies as well. In a similar way, if we prove that the models are equally accurate, they will have to go through the regulatory process, and once they're accepted, they will substitute the questionnaire.
Thinking to the part of the stratification model that integrates data coming from the wearables and so on, how may we use this data if these are not medical devices from the regulatory point of view?
This is the question. This is the discussion that we have to do.
Because
It's another
way we are doing a beautiful model that works very well, and this has to be validated before. But if from the regulatory point of view, I am not allowed to use.
Yeah. They know better than.
I don't know,
Well, I think that, first of all, if I may point out something regarding prediction. The baseline of prediction nowadays is the early detection. Right? Clinical medicine has been reformatted. And it's not that I'm saying so. I happen to be in a committee with MHRA in London dealing with predictive medicine. And we are very close to agree upon that prediction, the baseline prediction is early detection to start with, because there was no baseline, and each clinician could characterize or could define predictive medicine in his own or her own terms. If that could be of any kind of assistance to your project. In relation to Professor's comment, as long as we are talking about, look, proof of concept and the early verification stages of development of innovation, they are based on unregulated, chaotic research, basic research, globally. So I don't think that this kind of data, this kind of models that the consortium will come up will be useless or won't be allowed to be used for a pre-validation phase. The only thing that, if it's concrete and if there is evidence, right, because what we are doing as medical regulatory guys, professionals, we are running smart due diligence on the evidence that you're coming to bring us. So if this evidence is concrete, is at least has a rationale in its methodological approach, yes, we can consider this that it could be a very useful starting point to start your pre-validation phase. At the pre-validation phase, as long as you will say, you will call something that now I'm commencing validation, period, then it has to be medical. Or it has to be whatever you are coming by versus the standard, the state of the art, which was not the case right now, right? So, but what we have to see is the state of the art. There are three options. It's the international guidelines, the so-called professionals, as the ISO standards that no more or less they replace sometimes the state of the art and the state of the art. For example, if the meters can come up with a rationale that no, this should be the state of the art methodology upon my concept, the innovative concept, no one will disagree. No one. And regulatory wise, because I have a different opinion, point of view with Professor Tsiknakis. And I will tell you, the regulation, the regulatory development came up as an alliance, as an assistance to the basic research or clinical research or whatever you want to call it. But from the early stage, if you come up with a data that no, I have locked up my design, and that's my algorithm and period, that's my product, it will never work out. It will never get any kind of regulatory clearance, not even in India, believe me. And why is that? Because you haven't collected evidence at any kind of so-called well-known road. The pathway is totally yours, but there's no evidence because whatever is your personal claim, it's nothing else. So we need to see. Up to that point that you have presented, for me, it's brilliant. I mean, you can come up with brilliant verification data and stage of development. Then, yeah, definitely we have to come up to the proper validation of any kind of. The proper validation means that
Clinical validation.
validation.
Yeah.
Because
Technical validation, we can even in the context of CARDIOCARE show that technically
yeah, but are you developing the CARDIOCARE? Is it developing a technological solution or a medical solution?
as far as I'm concerned, a technological solution.
No,
A software, you mean?
no, a technological solution cannot be developed with health data. It's illegal. No. A medical solution based on a technological innovation, yes, no one requests from you that this has to have a regulatory clearance. God's sake. McGill University, most of its earnings, in quotation mark, per year, on calendar year, are from startups. All right. The startups, they do not, like McGill, they never come up with products, never. Only research use only. Yeah, research use only products are the ones that you are describing, the technological aspect. Because the software which will be used for the cardiotoxicity in cancerous conditions, like breast cancer that you are dealing with now, yes, could be a research use only product to be used by some academic departments, right? To run and then go one step forward to make it as a product, if that could work. That could be only the clinical aspect. That's the difference between research use only and the product.
Yeah, I'm always confused about the medical product and the technological product.
But digital health is not referring to any kind of medics. Digital health is on parallel of the same equivalent, the same significance with clinical medicine and clinical health if the aspect is depending on technology.
Totally agree. What I'm trying to, Dimitris, my kind of parallel, the risk model that CARDIOCARE seeks to develop whether the risk model takes into consideration data from the wearables, etc., from the task that we're working, is irrelevant. But assuming that the risk model is developed based on the clinical information and clinical data streams as described by Kostas. I'm aware that FDA has a line of activity and there is guideline into discussion regarding a regulatory approval of AI models, data-driven solutions, etc. So what I'm saying is that once the technological artifact is developed in the context of CARDIOCARE and we do technical evaluation of it in the context of the capabilities we have, that it was developed, it's fair, it's this, that, or the other, then there is a process to actually go through the regulatory process as I understand the regulatory process that the FDA describes in the guidelines regarding the regulatory approval of AI models, which basically, in my understanding, is something similar to a phase 4 clinical trial on drugs. You know, you've gone through all the previous phases, and there is a...
No, not at all. FDA, first of all, you are mixing up things. In FDA, with FDA, you can get a regulatory clearance, but not for a prescribed drug or a prescribed solution. If it's not a non-prescribed solution, right? Most of the guys that they are coming up with such kind of solutions and obtaining these kind of clearances, it's to raise money for their startups. And they do, based on the money that they raise, then they go and get the exemption studies license to start selling or using this solution within a state, for example, or with, for example, it could be done for all the Mount Sinai hospitals in US. It's a totally different perspective of view. However, if you go for a prescribed solution clearance by FDA, more or less, they require the same things. The only difference is that for Europe, the post-market surveillance and post-market clinical follow-up right now could be a burden of 20% more of your budget. In US, as long as you have the FDA clearance, this burden goes to 200%. That's why when you see that, all right, this company raised 200 million, and it's an AI solution for, let's say, prostate cancer early diagnosis. This is the reason only is because of the post-market obligation that they have to fulfill by FDA. And FDA is not doing like the Europeans do. They go every month on unexpected visits of these use places that you have registered or your device or your solution all around the United States.
Okay. I think that there are certain questions, one coming from Ricardo, on how we can use non-certified devices to have the risk certification. We will have time to reply to those questions. And the other question coming, from the discussion here, okay, if it's within the decision and so on. Okay, so
For me, it's not clear what is the product yet. What is the product or what is the service?
Okay,
Because there are so many things.
This is another question.
Risk is one, the algorithm transforming this into that is another.
Okay, we have to clarify it.
What are because there are
more than one.
There are more than one. This is something that maybe, Constanza, you have to do that earlier before starting the discussion. We have medical devices in Cardiovascular Health and CARDIOCARE, which is the next presentation by Constanza. And also there was a slide in my presentation, so we can go back there and see what are exactly and maybe explain. Yeah, you're right.
And the other thing is, I don't know what this should be open source or not.
Okay.
That was my question, because that's my question, because it's the same. So basically, in any case, we will come out with a product that is not a product, basically. The maximum that we will reach is research use only preclinical validation. Or
No, this is a prototype.
That
This is
prototype.
clear. Whatever we're making here, this is what it was discussed.
So we have the
But we need the
possibility
pathway.
going open source or looking for future co-developments and in a way maintaining the ownership.
No.
I see.
I will give again the slide that I presented, the overall progress. So to agree and see if there is any misunderstanding. That's clear. We're going up to a prototype. The prototype might be open source, it might be something else. Even it's an open source, you need clearance from MDR. Is that correct?
Yes.
It's independently, the business model is independent of the regulatory issues.
Dimitris, but who will go for a clearance? Will it be us, or we open it and somebody else may decide, I'm going to take this, invest in it and make it a
This
product?
is another decision, not for now. This is the business, the exploitation part that you're doing. And you know very well that. This is why we say that we have to discuss it. It's among us, but the regulatory, someone, let's say, comes to us and says, okay, I need the patent or the idea. We have to provide an idea of how answers to questions like the one set by Ricardo. This is the regulatory workshop. But we'll see. I propose to have the meeting for the lunch because we're late for the
And we
meeting.
have to shorten a little bit the lunch.
Yeah, and then you have 5 minutes. Okay, half an hour is enough.
Yes, yes.
Yeah, half an hour.
Okay.
We'll come back and we'll start with
So your question.
Paco, you.
I am Giuditta Callea, and I am an associate professor of practice at Bocconi School of Management in Milan. Well, by background, I'm an engineer, to clarify that I am not a physician.
So you are not teaching us how to have money?
No. I'm not teaching anything. I work in the government health and not-for-profit knowledge group of Bocconi. And I have been doing research in Bocconi for almost 15 years, doing all my research on medical devices, and especially in the area of economic evaluation of medical technologies. And I have been focusing on incentives linked to reimbursement. So how DRGs affect the adoption and diffusion of new medical technologies. But I also do some research on public procurement of medical technologies. And I coordinate CERGAS Bocconi Observatory on public procurement and contracts in healthcare. I have been doing some research on early feasibility studies in collaboration with the Ministry of Health, the Italian Ministry of Health. And so I was prepared when at some point a couple of years ago, IHI, the Innovative Health Initiative, that is a public-private collaboration, issued a public call to identify a consortium aimed to develop a framework for the future European Union Early Feasibility Studies program. You may know early feasibility studies. They are pre-market clinical studies for medical devices that were launched by the FDA in the United States in 2013 after a couple of years of pilots. The FDA at the beginning of the 2000s realized that they were losing their competitiveness because studies were migrating overseas. They were conducted frequently in Europe. And new medical technologies offer obtained the CE mark before the FDA approval. So patients had to fly to Europe for a TAVI or other innovative life-saving technologies. So at some point, they decided that they wanted to give an early access to their patients to new life-saving technologies. And they wanted their healthcare professionals, physicians, to be involved in clinical trials early. And they wanted, this is the main reason, they wanted to attract all the R&D investments back to the United States. So a huge commercial initiative, but they were successful. They are the first, they launched the program in 2020, the international standard, the ISO 14155, that deals with clinical investigations in human subjects, introduced formally early feasibility studies. They are recognized. They are studies that can be done. They can be done in a limited number of people after preclinical phase has been conducted, and there are no additional preclinical and non-clinical tests that may be informative to help the further development of the device that has not reached its final design. So it needs to be used on real human people. So these studies can be conducted also in the European Union, but we lack a framework. Competent authorities have a different propensity towards accepting risky studies. And so the European Union decided to invest to develop a framework. And we built a consortium. It was a two-stage project. So we first designed a public consortium, which is made of 16 partners. So Bocconi University is the leader, but there are a number of other universities, Trinity College Dublin, Marburg University are within the consortium. We have hospitals. We have Hospital Clínic in Barcelona, together with the Fundació para la Recerca Biomèdica. Sorry, I'm not Spanish, so my pronunciation may not be very correct. We have, well, Marburg, which is both a university and a hospital, Odense University Hospital, which is specialized in feasibility studies for digital health technologies, and Marburg University as well, as a strong specialization in digital. So we designed a task force dedicated to this type of medical devices. We have HTA agencies, the Norwegian and the Italian agency. We have a number of SMEs. We have some SMEs already experienced in the conduction of EFS, that is CARMAT, you probably know, the artificial heart. We have Neuronica. We have two very small companies, Idris Oncology and Curasoft, active in digital. We have a CRO, that is Meditrial. Who am I? Two patient organizations, sorry. EPF, so European Patients Forum and Global Heart Hub. And I think that's it. Then we have a pre-identified private consortium that is, there are 6 large companies who formed a consortium and are co-funding the initiative. The leader is Edwards Life Science. We have Abbott, Medtronic, the Synthes, Philips Medical, and the W.L. Gore. We in our environment, we also have an external advisory board, and we invited competent authorities from Italy, Portugal, and Ireland. We invited a larger number, but not all of them accepted the invitation. We have some professional associations. We have ESC, we have EACPS, EFORT, and the biomedical engineers. We have the presidents of national ethics committees in Italy and Norway, independent experts. We have Medtech Europe, that's it. Plus a board of patients, 11 members of the patient advisory group. So the idea is, this is what we are doing right now, to conduct some research and analysis to have a background regarding regulatory environment and framework in the European Union, characteristics, challenges, barriers for the conduction of clinical investigations for medical devices in the pre-market phase. We are designing a database, collecting detailed information on EFS that have been already conducted. We want, for instance, to investigate whether there are any statistically significant differences between recalls from the market and field safety notices of products that arrived to the market after an EFS with respect to similar technologies who obtained regulatory approval without an EFS. Next steps are to design a methodology, define the actors, procedures, timelines, define templates, for instance, the patient-informed consent, to define some metrics to measure the performance of the future EFS program. And we will test this methodology through a number of pilot use cases, helping us to refine the framework and then propose some final recommendations to the European Commission. I hope that I was fast enough and concise enough to give you a flavor of the project, but happy to answer to any questions. I put a QR code so that you may go directly to the website, to the initiative website, and eventually register to receive our newsletter. Happy to answer to your questions.
So your intention is firstly to come up with new KPIs?
Yes.
In relation to the potential early feasibility studies cluster or harmonized approach for EU?
We want to measure. Let's assume that at some point the European Commission says, yes, we will launch, we are convinced by your proposal, we will launch an EFS program. We would like to measure the performance. How many competent authorities approve the studies? How many studies are approved every year? What's the duration? How many patients? Did that study transition into a pivotal study? How many products were abandoned? Did the study attract any R&D investments in Europe? These are some examples.
No, it's a great initiative. My concern is that how you can evaluate and validate the misconception of the primary and secondary endpoints stated by the clinical study protocols, because in our daily activity we face more problems with the way that the clinical study protocols come up compared to the bureaucratic. Okay, Europe does not have a sense, does not have an understanding of the emergency case. But even so, the clinical study protocol describing primary and secondary endpoints for the same, at least to my experience, it's a mess. I mean, we see more than 50% derailment by each country.
We have identified roughly 700 or 800 EFS-like studies right now. We downloaded them, all the details in clinicaltrials.gov. And one investigation that we are starting is to have a look at the endpoints of each of these studies. So we will need, of course, the support of clinicians for the interpretation, for having a discussion, but we are going to touch this.
No, not necessarily.
Not necessarily, you don't think it's...
No, because look, go on the other side of the river. how many clinical studies of the multinational pharma companies, they went zero. I mean, at least to the place Roche, Novartis, Medtronic Europe, that we happen to collaborate at some point in Switzerland. We faced an extremely high number of unsuccessful clinical trials because of the non-correct assessment and writing up of the clinicians. Because it's not the CROs that they write clinical study protocol, it's the clinician, right? Or the scientist, the engineer, if we're talking for a digital health, right? If I don't have the support of Dimitris, no matter if I request from the clinician, the primary point will be totally lost in space. And we faced several cases with Dimitris for us and some other examples. So we're requesting too much from CROs, and we're requesting much more from clinicians, and we are not understanding the rationale of FDA. FDA is always in the committee, clinician along with the bioengineer and biostatistician. Right, so here is nothing. I mean, I can send to the Greek competent authority. It could be a biologist evaluating a clinical study protocol for a continuous monitoring system, a wearable in cardiovascular disease. Okay, how come? I mean, what kind of university has he graduated also? This is the problems that you're gonna face, and really happy to find out the outcomes. Great problem.
Thank you.
One question, are you splitting a little, are you taking into special considerations the peculiarities of software as a medical device within the project? And to what extent are you tackling real world evidence, real world data studies or factoring this into this feasibility? And then the other one is notified bodies. Are they?
I forgot them.
Are they involved?
They are in. I forgot.
Okay.
Don't think. No, we have Team NB plus IMQ that are part of the external advisory board.
You have a couple of them, but not the.
No, Team NB. We invited because we personally knew IMQ in Italy, but we also invited Team NB, and Team NB designed a couple of so they involved the BSI and TÜV Süd.
Okay.
So they participate both as with the director François Schlemmer and with some representatives of individual notified bodies.
And you collect their opinion into this?
No, they attend our meetings, they participate. Yeah. I forgot to mention that. Yeah.
Judita, let's make a hypothesis.
No, there's part of the first
No,
question.
he wants me to answer.
Yeah.
Okay.
Okay.
So software as a medical device. We have, as I mentioned, a task force that is dedicated to digital technologies. We want to understand the meaning of early feasibility studies in digital and software. I had an exchange with the industry, and they reported to me that in the United States, the FDA is struggling because if software is an ancillary component, if it is a telemonitoring, for instance, then they see the possibility to have an EFS involving that technology. But they struggle a little bit if it is a standalone software. They are not so convinced about the possibility to do some EFS for this type of.
I have a question on this approach. How come FDA would sponsor early feasibility for standalone software as medical device, since most of the cases they come up with a predicate device, the technical dossier, predicate devices in the US. I mean, for me, this is a bit contradictory. If you go to the technical assessment process of the standalone software as medical devices by FDA, they are going mostly more than 80% with the predicate device, like an equivalent devices of the MDR and IVDR is called. So here in Europe, you cannot easily do this because according to MDR and IVDR, in order to come up with a predicate device for standalone, first of all, I have to go, if I use, for example, Medtronic's one, I have to have an agreement, a legal agreement with Medtronic, that I am allowed to use their data for the sake of my innovation. For God's sake, is there any company which will allow this? Never.
No, but this is my point. To what extent there is no one trying to disentangle the elephant in the room, like with the new things coming on artificial intelligence, with the new things coming on real world data, with the new things, we have a regulation that is kind of, hey, you have an AI, don't use it because otherwise it's not going to be software as a medical device, transform this into rules. So I would like to see the group working on, and I see that this could be the group,
Yes,
no?
this could be the room.
But
We are going
right
to
now,
this, we
it's a
have.
paradise for Europe.
Sorry?
Right now, it's a paradise for Europe. Most of the guys that they come up with these kind of solutions, they register them, they not even regulate them through the competent authorities, the ones that they don't respond to you. That's a class 1 device. Most of the software, standalone softwares in Europe, they're class 1. So they come up with a non-existent technical dossier. And the feasibility study is 0. I tested in my clinic, 10 patients, period, this is it.
Yes.
And then I have a postdoc writing up a systematic literature search.
But this is now.
This is now.
I'm talking about the meeting takes place in 2024. From 2026, we can have another meeting.
But we have 2 years to debate, no? Or we wait until.
No, because the
2026?
regulation is there. The EU Act. No, the AI Act is there, it's voted, it's in full power from 2026. But what if you go through comparing MDR with AI Act or by EU, it's a joke because either you have to spend triple amount of money and in relation to prolonged period for regulated, or going back to the old story of systematic literature search. So the feasibility study will have a place, a strong place in this from that period, but it won't be a real feasibility study. It will be a definite validation study, but at the model that you're presenting, in order to come up with a final regulatory clearance. Because the guys that they made up the AI Act, they never went to the MDR guys or the IVDR.
No, they went.
Okay.
They went. Otherwise, it's that they don't talk to each other. But they went.
They went, but to.
And partially, some of the heads of units that were there were head of units of the other unit before. So.
Okay. For me, that we are facing on a daily basis requests for assessing technical dossiers, the reality is totally different.
No, I understand this. But this is why this title and what you are saying seems promising, because it's like it's like there are 2 regulations that what we do, postpone again the transposition of.
No. But to answer to the second part of your question, real world evidence. So anytime that the technology, the device is used, that device may be different to the technology that was used previous patient. So the product may undergo modifications after each utilization.
The product, the algorithm.
Not the product. Well, I'm talking about products, the algorithm as well. It may undergo modifications. Okay, so we are going to investigate how to use data collected within these studies and how will notified bodies use? Will they consider that evidence and how? This is one of our goals. No, I think he was first. You wanted to say something?
No, just that
that-
you had a question that is.
Here I am.
Yes, Judith, first I wanted to thank you for the involvement in the project. So Professor Szymanski from the Regulatory Affairs Committee of ESC participates. And I think it's a very important topic. And we are really discussing this in several meetings. We also had a CRT workshop or cardiovascular roundtable on priority pathways for medical devices. Also, Andrea Rappagliosi was there from Edwards, so we follow the topic closely. Just a comment, this is really promising. And I think that it's also important to make a comparison to regulators with respect to medicines, pharmaceuticals, because this is something that is already there and it's working. So it is important to remind this, and also in relation to unmet medical needs. That is a topic more and more discussed. Early feasibility studies are really, really essential. And then I was also wondering in terms of timing, do you know that there's a medical device regulation that will undergo an evaluation report from the Commission? So I was wondering whether some partial outcomes could be shared with the Commission by then, because it would be a good opportunity to see if this framework could, in preparation at least for this framework, some space could be created there to introduce.
Yes. Thank you for this, for raising these points. So unmet medical needs are part of one of our work packages that is starting these days. We are starting a methodological work package that will discuss eligibility criteria. Which devices are suitable for an EFS? For which conditions? For which unmet needs? What are the clinical sites characteristics? So where, in which type of hospital can we go for an EFS? Which clinical competence is required? Conditions for reimbursing the investigational device, for instance. So we are going to touch, I had the opportunity to discuss with Piotr at our kickoff meeting regarding unmet need. I was hoping to meet him today because I wanted to let him know that I was working on this. You're right when you say that we are moving into the evaluation phase of MDR, and in March, I had the opportunity to present this project at the Clinical Investigation and Evaluation subgroup of Medical Device Coordination Group, and together with the Professor Carricone and Tom Melvin from Trinity College Dublin. And after that meeting, we had a separate meeting at DG Santé. We presented the project to Flora Giorgio and her staff. We are very much interested in the work package that is dedicated to key performance metrics. And we will, they don't know it, but we will invite one of them as a keynote speaker at our yearly meeting because they asked to receive documents. They are happy to cite us, to use our results in case this fits with the purpose of evaluating MDR. So we are in touch with them, and yes.
Thank you.
Thank you.
Judith, let's make a hypothesis. The hypothesis, you have seen what is CARDIOCARE. And I'm saying to you that this is a good test case for you. Can we develop some kind of collaboration?
I think so. Why not? You are part of the advisory board. So you as ESC are part of the advisory board. But let's discuss. Yes, we want to do many case studies, interesting case studies. We are designing case studies to interact with the patients, because we want to develop a methodology to involve patients in the development of designing devices and clinical studies. So we recognize the value of case studies. Happy to consider collaborations.
Maybe case studies as patient, but also you may need to consider startups. instead of having a patient as
Yes.
entrepreneur, because they are facing sometimes the same that.
Yeah.
No,
Yes.
What I would like to see from a project like that is a comparison between this, to have two different categories of the EFS. One, because if you put too many constraints, then you will have an RCT, a randomized clinical trial, right? Period. That's the definition of RCT. So definitely you should do this, and with the opportunity of this project, it will be worthwhile because I know that well-constructed or constrained EFS model. And to compare the results, because that would be a great boosting for Europeans, for Europe, to find ways to adapt real-world data and to come up with the real-world evidence. Because everybody right now talks about real-world data in Europe, but still, at least the meetings that we participate, it's a very gray zone of the clearance of the real-world evidence, which is the primary point. So if you ever consider with your project partners to have this kind of clear, two different distinct models of your EFS, it would be really
We will consider
innovative, and at the end of the day, you will have findings, right? That which is the request. Because to imitate what EMA is trying to do, it will never work. Pharma is a totally different story.
Totally, yes, pharma is
Right. But in medical devices, it's a totally new landscape, which needs firstly to be well clarified and normalized by the professional users, academics, clinicians, engineers, regulators, competent authorities, policymakers, etc. And to have an impact to the end users or the patients.
I took note and will consider your comments. Thank you. Thank you very much for all your comments. Thank you.
Thank you, Julita, very much. You know, a much closer, let's say, collaboration with what you're doing. Okay, I think that now we're at the point that we should come back and answer some of the previous questions before going to you, Petrus, because it's your turn now. Can you, Nicholas, link my presentation? Just 2 minutes, Petrus.
Take as much as you want from the beginning.
My presentation.
Don't misunderstand me. I don't want to provoke you. I just want to provoke.
No, I understand, but sometimes you see the fights between, I mean, they should talk, but I don't blame neither of them, you know what I mean?
No.
They are both the same, but you know what I mean? But the funny thing is that.
I have a taxi in 40 minutes. Am I allowed to stay, or is it restricted? Okay, thank you. Otherwise I move to.
No,
okay.
absolutely.
The second one is not
Absolutely.
like how that you have lens.
Okay, I will try to go back, starting from Paco's question to understand, and also to come to Anka's comment on that issue. This is just to make that in the presentation mode at the beginning, please. Please go on. Yeah. Okay, fine. Okay, here we are. I have described, that's just to describe here, the main outcomes of the project. Of course, those will be finalized by Anka, because it's part of the exploitation strategy.
Yeah, but it doesn't mean that I'll do the exploitation.
The exploitation part. Okay, first of all, we have data sets that we're producing that you addressed very well. Okay, at the beginning with the health data spaces or whatever we need to do with that. Usually for the European projects, okay, you know that you have an obligation to make those open somehow. Okay, we have not clicked, this box at the beginning, but it's a question for us, and I think that Paco gave us very good ideas, and Karim is coming also to act in this direction. Okay, Paco, from the regulatory point of view, okay, because the European health data space now are becoming a regulation. Karim, because we have implemented a lot of data spaces, and we will give solution, let's say some solution to that. The second part that we have is the health solution that we provide. The health solution, I tried before to describe what is that, but basically is a means for monitoring the patients, collecting the data, but apart from that, we're using the health solution to provide, the intervention to them. So it's monitoring and intervention. This is the way that we're doing that. So it's the first outcome, the health solution. This is already developed and is applied, in our clinical study. Our clinical study, we have an arm taking the intervention. It's half and half. This is for details on the clinical study. Cassandra is here, so she can explain to you. Then we have the IT infrastructure that we have built for collection of data, which is a platform which is used for multimodal data, clinical data. So we have the CRF that was developed by Philips attached to this platform. But there are other data coming, like the imaging, the genetic and the mRNA data, the data from wearables, and also the patient reported outcomes, the questionnaires that Manolis mentioned before. So it's a platform, okay, that can be used for collection of data. We found it very useful because now the experience that we did and the experience that we got from this is something that we applied to other projects, not only European projects, because we're collecting any type of data, and it works. Finally, okay, there is stratification and the treatment, the selection of treatment. So it's the algorithms that we're building for stratification based on the data that we have collected. Okay, so there is a link between the data and what we have developed here. In order to monitor the patient, which is one step, and the other one to select the therapy somehow. Okay, so it's a tool for management of the patients. So this is the main outcomes of the project. So I think that more or less are clear. Of course, some of those can be used, as one. I mean, you don't have 4 different parts, but you have just one solution, the CARDIOCARE solution. But I will leave that, to Petros to give us advice to that, because even, for sensors, Manolis, and the app that you're using to see what you're collecting, Petros always was saying, make 2 different medical devices. Because one, it might be class 2B, the other might be class 1, and for class 1, you have the opportunity to change it, frequently, update it without going all these regulatory steps. So there are a lot of ways to exploit that. Coming to exploitation, to answer to the second, we have all those things. Of course, we can make them available, as something that might be open access software or whatever software is that. But we're not discussing about the business model that we follow, but we're discussing about the regulatory of these issues. So we have to define what do we have. More or less, even 2 lines here is the intended use, Petro. I don't know if it's enough for you. And then we have to go to the next steps. And this is the purpose of this workshop. So Petro, now it's your time. I mean, purely regulatory. Petrus will say a few words about him, but Petrus is coming from the real world. I mean, he's doing the work not for research. He's living from providing services, to medical device companies, especially. Okay, and we have done these experiments with medical devices several times, and we know both of us the procedure and how we're doing. But Petrus, say a few words about this.
Yeah, hi. Once again, originally I'm Greek, but I'm residing in Switzerland, in the French-speaking part of Switzerland. By training, I'm a medical doctor. The past 12 years, though, of my life, I'm dealing mostly with translational medicine, and part of translational medicine is regulatory affairs. And the regulatory affairs comes firstly with quality assurance, and then you're moving the quality to the regulatory affairs. What we are dealing with is we are assisting from early phase clients. Even from TRL2 and going all through the way, not necessarily for TRL8, because we are assisting also university hospitals and organizations to move up towards a proper translational development of their research. Thanks a lot for the invitation. Thanks to Dimitris, and really honored to meet you in person, all of you. What I'm gonna try to describe is now I'm doing.
Works.
All right, great. Just to make sure that you have understood this. That's the slide out of the 50 slides of my presentation. If you remember this, that's more than enough. What I want to say is that, all right, now we made by Professor Tsiknakis the preclinical testing, everybody is happy. Then we are moving with the clinicians with the clinical investigation, but still it's a long way for the clinical evaluation report, which has to be supported by a clinical evaluation plan. And this clinical evaluation plan has to be agreed with more or less with the regulators, because you are already at the stage of the validation, and the clinical evaluation plan is a bit tricky, because most of the notified bodies in Europe, they are using epidemiologists and statisticians, and not the so-called clinical doctors, as I used to be. So it's a different perspective of view when you are talking, when you're going to evaluate a plan from the statistics point of view, or from the point of view of the clinical significance of it. Okay. What I want to say from this slide, just keep in mind we have the modifiable and metabolic risk factors and the non-modifiable risk factors. Based on this, these are the factors that they do characterize the risk evaluation of your innovation. In order to do so, you have clearly to define upfront to any kind of regulator, meaning to yourself, because you are the regulator of what you are doing in research, not a notified body or FDA. And which are the modifiable behavioral or metabolic, both of them, or the non-modifiable risk factors that you have to address, you take into consideration towards the research project, which might end up to a product or which might end up to Nature publications. So MedTech Europe, it's always a very good alliance on this kind of innovative pathways. And okay, the focus is going through the prevention, detection, and diagnosis of the cardiovascular and health, and that's the plan that and the policy that they are promoting a lot towards the cardiovascular medicine, since we are in the European Society of Cardiology, and thanks for that. Now, first step that you have to come up is with a proper to define your strategy in the regulatory field. If you don't define a priori your strategy, then it's a bit awkward to say that you are dealing with a structured research project. What I want to ask you to remember is that this strategy applies to all the stakeholders of the multidisciplinary research project, meaning that it's not only the engineers, the biologists, the clinicians, but even the CROs that they might take the final clinical study protocol, and in order to implement it properly according to the good clinical practice, etc., etc. But still, even these guys, they have a priori to be into the track to understand and to agree upon the strategy that we are taking. Definitely, you are all very familiar, and I think that you do like more FDA than European regulations. Not bad at all. However, the 510K, let's assume that you are taking the 510K. The 510K, which is the simplest regulatory pathway for FDA, is the only regulatory pathway which ended up to that much of trillions of wasted funds. Because 510K to obtain a regulatory clearance by 510K, you are not getting any kind of an actual benefit to enter the US market. There are other preconditions as well to enter compared to the MDR. Now, my opinion about MDR in one word, the Europeans, they are always going, if the Americans, they are pushing, they're going always to the highest level of, what do I say? Not obeying, but they created a regulation which is not a regulation to promote innovation. All right, it's very costly, it's very time consuming. Most of the notified bodies, they have not been trained properly, and this is easily why I'm saying so. We had been asked to assist one big notified body to overcome their effort to get MDR clearance. They came up, the first audit came up with 572 non-conformities. If you have 572 non-conformities as a notified body, okay, one way or the other, at some day you will get the MDR clearance. But that means a lot about the infrastructure and the quality of the people that you have. All right. Anyhow, that's life, and we carry on hopefully with the next slide. I think that the previous project regarding the early feasibility studies covered this slide entirely. What I want to say is that now UK is a different story, right? MHRA is not under European regulations. Right now, it's a mess. So an easy way to enter Europe as a context is to go through the MHRA, not through Europe per se, through the MDR, because they have more or less they have adapted they have kept the MDD or the IVDD and modified slightly towards MDR or IVDR, but not yet there. So we're expecting that to have the new regulations by MHRA by 2027 So until that period, it's a paradise for innovation. If someone wants to enter to get a regulatory clearance, yes, MHRA is much faster than the rest of Europe through the MDR or IVDR. And let's start with the compliance story. The compliance story, as you see, it's not only regulations, right? It's not only those policies, but still it has too many requirements, but also standards, laws, etc., etc. And it's always a very difficult issue to achieve. So we have to pave our way for compliance at the very early stage, but also to continuously evaluate the compliance. And in order to show, we cannot say that, okay, I was surprised because European Union came up with, European Commission came up with a new legal change in the MDR or IVDR. It's not a problem. You have to stay ahead on this. And in order to do so, always you mitigate your risks. I mean, that's the main point. It's a risk mitigation play game, monopoly, both MDR and IVDR. If you cannot be familiar from the early stage with this mitigation risk strategy, then it's not worth to try because you're going to lose your money. And at the end of the day, the product that you come up will be not of such high quality. So we have to actively monitor the regulatory updates. I mean, for example, apart of Paco, I think that the rest of the guys, you're not familiar what is going on with MDR and the new updates, MDR, IVDR. It's a joke. I mean, every 6 months, the European Commission is informing at which aspects of MDR we have updated the regulations. And that has very difficult to be applied to the all the stakeholders, the supply chain, right? How you can educate and train biostatisticians or clinicians that they are in charge to evaluate CEP or CER, if things are changing just like that, or when the AI tools, validation tools that are coming up, and I suppose that you're working on that, correctly, then it's going to be a real mess because, all right, very few in Europe, they can have a real understanding on what we are talking about. But I forgot to mention this. Since we are talking about medical device, please, start with a proper quality management system. If you, and you're going to tell me, yeah, but we're not a legal manufacturer, so who is going to be certified by 13485 in a consortium like CARDIOCARE? But I am not saying that to be certified, but you have to be aware and to train the whole consortium as per ISO 13485. And why is that? Because if you don't start from A, there's no way to reach Z. And the same story that, yes, but our project, our proposal, which was accredited, was not referring that I'm going to come up with a final product, but it's going to be just TRL6, for example, for the sake of the time. No, it doesn't work like that, because if you reach a level of TRL6 without even considering ever during that period the ISO 3485, all right, forget and go to another project. That will never become a product. Just to remember for Professor Tsiknakis, the regulations as well as the relevant ISOs, they're referring to the whole life cycle of the product. Whole life cycle of the product means TRL1, TRL, whatever you are claiming right now. So when your PhD student came up with this finding, with the first publication, and then you move on, and now you are in the TRL5, throughout the life cycle of the product. So what's the impact? What is the impact of a proper regulatory oversight to have safer medical devices in Europe? For me, that's the main thing. So before, when with Dimitris, we had the opportunity, a part of being friends for a long time, to collaborate in several projects, and we are always insisting and pushing a lot that at the early stage, around the SWOT analysis of your project, of your idea. If you cannot, if you don't have a clue about that, how come you're gonna come up with the minimum understanding of strengths, opportunities, but also weaknesses and threats of your project? And your project is innovation. Even if you're gonna lose a proper Nature publication and go, unfortunately, to the archives because of a non-proper SWOT analysis, it's a pity because you deserve it. That's very nice color on the left hand side, all right? What I wanna remember is what I wanna point out, the MDR is replacing the Medical Device Directive, the MDD, the so-called MDD, and the result is that there's significant increase on the demands for scientific, technical, and clinical data, meaning that if evidence is missing in any part of this, either scientific or technical or clinical, then you're not talking about MDR. You might discuss for something else, but not for a technical dossier as per MDR. As you can see, I have put here the Medical Device Coordination Group, the MDCG, which is more or less the best legitimate guys that they come up with some kind of proper solution, driving consortia, driving manufacturers towards the right way. But still, the MDCG is always updating and updating because it has to come with new guidance documents. Otherwise, you're going to be lost. And at the end of the day, Europe will never be competitive, all right? And okay, the last one that we always want to see the real final draft of the official journal of the European Union. This is the fact, because many people, they made it think that they're going through the previous drafts and they never go to the ones that they are published on the official journal, and they face surprises afterwards because this one way or the other, it's a gap of like 3 months, the latest draft that it will be published until the final modified evidence. Let's go now to the classification. We have how many categories of medical devices? Class 1, the most, as I said before, most of the standalone medical softwares, as the Americans like to call them, they are registered, not even certified, as class 1 by the national competent authorities in Europe. That's a big business for everybody, even for the Chinese. Most of the German competent authority is dealing with Chinese companies that they are pouring their innovation in Europe through this regulatory aspect. The class 2A, class 2B, and class 3. Okay, this is a risk stratification. The classification is based on risk stratification or risk categorization of your device. So it's very clear. However, just bear in mind that the class 1 device has 3 subclasses. The IS stands for sterile, IM is for measuring function, and IR is for the reusable surgical instruments, like the dentists that they are using, etc., etc., etc. The MDR sets new standards for clinical trials. And why is that? Because you have to prove that your data is robust and reliable, and not it's your self-claim. the quality and the safety requirements of the performance of the clinical trials, it is equivalent or similar to the pharmaceutical ones by EMA. Now, software plays an important role, and we have very clear pointing by EMDR on this aspect. Classification rule 11. You cannot play around. So whatever, right now in the CARDIOCARE project, you have described more or less 6 products, 3 different products, to my understanding. And I will come up to the end because it might be more, but definitely not less. But these products, they should follow the classification rule 11. It's straightforward. There are no surprises there. Here you are, complexity. Okay, most of the guys, they had products and they're gonna still have products until 2027 per MDD, Medical Device Directive. Does anyone know what is the official terminology for a device which exists for MDD and it has to go through MDR? It's the legacy device. So if you see in the journals of European Commission about legacy devices, these are the ones that they used to be certified. They are still certified, so lawfully they're in the European market. But these devices, the manufacturers of these devices, they had to submit an application and approved by 26th of May, 2024, almost a month ago, that they accept to go through the transition process in order to be certified as per MDR. And there are specific deadlines on that. If not, these devices will go somewhere to Africa. So whenever you are using, Professor Tsiknakis, several devices, play around with legacy devices. This might be a good solution to you. Legacy devices. Because they, most of the times, these devices with MDR, they should be in a higher classification rule, but because they had an opportunity through MDD, they were in a smoother way. So you can use them to your clinical verification, development of your softwares. And with the exception of class 1 devices, that the competent authorities, they have to be in charge of their technical dossier submission. All the rest, they have to go through the European notified bodies. You know the story about the notified bodies? Notified bodies are independent legal organizations. They are controlled by European Commission. They are audited by European Commission. And members of this team, of this audited team by European Commission is the representative by each competent authority of the European Union, plus Switzerland. And Switzerland until 2027, they are in charge of the clinical data that they are submitting. The only solution for please carry on. It was a pleasure.
It was a pleasure. Bye.
Bye.
Thank you. Bye. Bye.
So you have to be well in advance prepared and to take action, not by scrutinizing your project or your research effort, but at least to take into consideration what's going on into the regulatory aspect of your research. And you all referred by now many times to the clinical studies or the clinical data that you are using. Clinical studies, clinical data, they have being collected or have been implemented by specific ISO for clinical practice, for clinical trials. By that, it's a regulatory, you have entered the regulatory world. It's not only quality, but it's part of the regulation. So, and this regulation is referred to the national competent authority per each country that you are running. All right, so bear in mind this, and because usually in the research project, what we are saying is that, all right, it's a research project, and we're not going through a final evaluation of our outcome to become a product. Who cares? Now I'm talking about how you run the project, about the legitimacy of the way that you are executing the project. Anyhow. Since you like a lot the story of the wearables, especially my new friends from Crete, the wearable story. The wearable story, unfortunately, it was the big promise for the modern clinical practice, but still we have an adaptation and acceptability rate in the best case scenario of just 25% by the patients. There are several issues, discussions, and why is that? But still, unfortunately, it remains too low. And this is the reason, unfortunately, the lady has left. This is the reason that FDA was always more flexible than the Europeans, for obvious reasons. FDA is a single country's regulatory body. Now we have 27 countries. But still, how you gonna promote and enhance the quality of life in Europe for patients if you don't accept and adapt the digital health solutions in your life for your patients? Everybody is talking about prevention in medicine, but still, I don't see people like me of a specific age, overweight, to carry on at least in a preventive manner, some kind of these smart tools that they could give me sort of an idea, okay, the way that you are going, most probably you're going to have a heart attack, so visit a cardiologist, all right. This kind of stuff. And you will see what I want to say at a later stage. Yes, the digital health Professor Tsiknakis includes e-health, m-health, and any kind of internet-based health. We are talking about digital health, and this has been accepted globally, thanks God. Definitely, they will come up with several approaches. For example, Constanza was your name. Sorry, you talk very nicely about digital therapeutics, which is part of digital health. But there's also digital diagnostics. But also there is also digital monitoring. Right? Because now we are talking about chronic diseases, and if we cannot ensure a proper monitoring of the disease, what kind of diagnostics or what kind of therapeutics are we talking about? Now, we have several approaches, several clusters of innovative development, excuse me, in the digital health spectrum. For example, a smartphone, WhatsApp is used widely in US for the imaging exchanging between the hospitals. I have an MRI of my patient, so I'm sending this to my reference hospital, so the more senior consultant, more experienced consultant can see it. So WhatsApp has got some kind of clearance, unofficial clearance, but under certain conditions in the US for images exchanging and transferring for diagnostic purposes, re-diagnosing purposes. Now, smartphone-based surveys, like the lecture by Professor Tsiknakis, yes, we are talking about we have to find solutions to collect as much data as we can, but in a friendly manner, in a smart manner, through this mobile apps, this kind of technology. And why is that? Because then the data guy can control this, that everything has been by the book, and this data has been collected by this way, has been stored in this way, has been processed or not processed, and has been transferred to that manner. And not that everybody is doing his own way, the way that he wants to. Right now, the most successful story in digital health in cardiovascular disease is the devices, the solutions in relation to atrial fibrillation. They have huge sales, not yet profitable, but still they found their way. They got FDA approvals as well as European Union approvals. Half of them by MDD, half of them though by MDR. And this is very important. Everybody is talking about stroke prevention. But if you are a high risk or a moderate risk and you cannot have a simple way and not that expensive way to monitor the patient, the rhythm of the patient, in order to predict if he's going to have a stroke or not, or due to an AFib story, exacerbation, then the solution is not there. We are discussing again about healthcare 1970s here. Now, I'm health interventional platforms for dietary behaviors. Don't look at me. But still, they are working quite efficiently, especially for the low and middle income countries, which is a huge problem because these guys, they start facing a booming on their health degradation due to the westernized or more civilized standard of living. That's the only way to prevent the exacerbation of the diseases there, because we cannot. No one wants to build hospitals there. No one, not even themselves. No one is expecting that the guys. I will give an example from South Africa. All of a sudden will become medical doctors to serve the healthcare system. They can study other things to be rich and not medical doctors. So they will always have a shortage of both hospitals as well as experts in order to do so, to support the improvement of the healthcare. And now we are talking about the clinical decision support system, the so-called CDSS. In Europe, we are calling it DSS, decision support system, but still the Americans there, they have an absolute right, because when we are talking about clinical program, we're talking about the clinical decision support system. At least it's related. So we have to use the proper term. And there we have a great interest by everybody to move to this kind of solutions for at least the major chronic diseases that Western Europe, excuse me, China, United States, Brazil, India, and Australia, they have fully prioritized this kind of solutions. Now, what is the challenges that we are facing with digital solutions? To be frankly honest, up to now, there was no straightforward pathway to understand how you design, verify, validate, and then there's another big question. How you ensure what is the strategy and policy that you as a manufacturer, you follow for post-market surveillance and post-market clinical follow-up? Because, all right, let's assume that the story is that until the time that you get the MDR clearance. No, the European regulation has imitated the American way of following up innovations and new devices. Meaning that from the day that your product will be in the market, the notified body every year will come to evaluate the technical dossier, but is gonna request the evidence that you have collected. And this has to be clinical evidence. They are not requesting that you're gonna run randomized clinical trials, for God's sake. They are not requesting any kind of clinical investigation, as we call it in medical devices. Not at all. They are not pushing people and companies to spend money in this direction. But then they come up to your point. Where is your real world data that you have collected, and what are the outcomes of this? In a year's time, somehow, okay, you are not good in sales, but still you have used in 3 European projects and you are participating in clinical studies involving 300 patients. All right, give me this data randomly. I don't want to see the clinical study protocol, nothing. Randomly, the data that you have collected. This is a very important but very difficult thing. AI in imaging has a stronger interest than the imaging per se. This is the reason, for example, that heart flow paradigm. Are you aware of heart flow? The American company, which is more or less the real valuation of it is 1.5 billion, is that they came up like what you are doing here, CARDIOCARE. Exactly. So it's an AI-based company which provides an so-called artificial FFR, simulation FFR, but it's been used hugely. And why the radiology companies they are investing? Why first was Siemens, then it was Philips, then it was General Electric. It's the only company where all the big ones they have contracts with heart flow. You know why? Because they want to try to optimize their imaging processes through the technology of the images, of the reconstruction images that the heart flow is providing to them. That's the only interest that in modern radiology, and that's the assumption is that for the next 15 years, only AI in imaging will have an interest by the big ones, nothing related as a core subject, I mean, to the imaging per se, as we have been told in the medical schools. Now, IVD sector that my Italian friend has said. Now, we have the lab on chip, the electrochemical test strips, the lateral flow assays, and the molecular diagnostics. The future is molecular diagnostics. If I would be an auditor, what I would ask Professor Fotiadis' coordinator would be, okay, you are evaluating cardiotoxicity in patients that they are receiving specific medication, anti-cancer medication for breast cancer, all right? This medication is applied by EMA. All right, so I can have full access on their technical dossier, what they have submitted, along with all the relevant data. So side effects, serious adverse events, etc., etc., etc. Let's follow up and see these biomarkers, any kind of markers that you're collecting are related to the existing data SEMA has already in their depositories, or if you can come up with new findings that you can enrich the EMA preconditions for the announcement per each individual drug. What is that? That they would say, okay, Professor Fotiadis, where is your proposal for a companion diagnostic in the specific in relation to this oncology treatment? X, Y, Z, for example. Since you are referring to genomics, since you are referring to molecular data that you're collecting, why you are not correlating then the evolution of this cardiotoxicity, the evolution, along with the omics profile and the rest of the data that you have collected. This is a companion diagnostic. And the companion diagnostic was the only reason, believe me or not, that the Europeans, they had to come up with IVDR because they know that IVDR cannot be supported by European medtech environment. It's too expensive, too difficult, the way that they are coming up. But if you go to and ask any kind of pharmaceutical company nowadays, where are you putting your money for R&D? It's only companion diagnostic. And why is that? Because they want to see the disease progression in relation to their compounds, to their licensed compounds. That's where the R&D stands for. To cut the long story short, we are moving to the monitoring innovation in the remote patient monitoring. RPM is the biggest cluster of innovation in US right now, numerically. The money that have been invested by universities, not by companies, by university departments, towards the new technologies on remote patient monitoring is the double of the pharmaceutical basic research in the university is in US. And last but not least, the wearables, like the skin patches, like the accessories, the smart clothing, and numerous of other innovations. But I'm referring at least to the ones that they have been into the market right now. And there are others to come. Now, we have to keep in mind that we are dealing with innovations, with research project, which has one aspect to monitor the health status. To prevent, as if I understood well, the CARDIOCARE, or to detect, to diagnose the disease, the cardiotoxicity indeed, if we're talking for early detection, all right? And at the end of the day, to what? To deliver patient-centered care. That's what the CARDIOCARE stands for, at least to my poor understanding. And based on this aspect, Dimitris, you have to identify when the project will go towards the end, which are the real products, the real innovations that you can come up per each cluster of the core aims of CARDIOCARE. I'm repeating myself again to my understanding, not. Just remember that we have medical devices for real-time monitoring and just giving ideas for potential innovation for CARDIOCARE. Mobile and web applications, which could serve as the interface between the user and specific technologies. Health information technology that Dimitris was referring to the previous slide, which of course accommodates EHR, etc., as well as fulfilling all the prerequisites for the large big data depositories in accordance to the applied EU regulations, in order to do what? To enable the big data analysis. Otherwise, everybody is talking about big data. But when you're asking, all right, what is your big data? They never show to you because there's no big data. And in Europe, it's very difficult to find real big data, to be frankly honest, as it stands right now. And to the AI per se products innovation that you can come up. And all of this, they will create what? New clinical care models and support even decentralized clinical trials. For example, the lady before, she was referring to a new, to a pivotal component of the clinical trials testing of digital health. But here is the example. And when you have a clinical trial, that's the point that it was early in the morning discussed. If you will be able to characterize as a research use only, meaning that you have created the technical dossier without though the clinical validation, so it's a research use only, you are allowed under certain circumstances to use this technology into clinical trials. And why is that? Because you want to use the scalability more of them towards the decentralized form of clinical trials, which is the request by European Commission as well. So I think that there are too many things to be discussed, but the time is short. Let me go again to the cardiac arrhythmia management. That's the most successful paradigm that I referred to earlier on. The remote heart failure monitoring is the best success, the best successful scientific outcome of endless numbers of years of research. And in nowadays, it demonstrates has a strong evidence that it leads to, excuse me, to a reduction in heart failure hospitalizations. That's the main outcome. No one is expecting to cure heart failure, but if you can minimize, yes. And how you can do this with the incorporation of pulmonary artery pressure sensors. Of course, the clinicians, they are well aware of the implantable loop recorders, etc., etc. For the sake of your time and Dimitri's stress, I will try to skip most of the presentation and try to just to hear is a very significant part, the UDI. That's the real a revolution in European Union, European Commission, because they have adopted the FDA's requirement for UDI. And UDI is the only tool to trace medical devices and the use of them. So, you know, in Europe, we don't have a common platform for recalls. We don't have a common platform, a data bank that you can see serious adverse events, etc., for medical devices. You have the yellow paper, the yellow card for the pharma, but not for medical devices. So that was the only way that the Americans could push the Europeans and the rest of the world that if you don't have a UDI, forget, you are not a legitimate product into the proper healthcare system. The registration process that you were referring to, it's as simple as that. It comes with the planning, early planning, then you have the implementation and the maintenance, the post-market, as I said before. What's new in the MDR? MDR requires a quality management system. If you cannot prove that you have an acceptable, does not refer to a 3485, but if you cannot prove that you have developed something in accordance to an acceptable quality management system, then you cannot be certified at all. Now, the clinical investigations, we have not only the process, but we have the PMCF investigations as well, which is very, very crucial. And my advice to you as a consortium, CARDIOCARE, is that you start developing SOPs, standard operation procedures, not because you're going to be one day manufacturing company or manufacturer, or they will be certified. But that's the only way globally that a consortium or multi-stakeholders project can follow the same pattern of the same guidance, targeting the common outcome, the common request. Without an SOP, no one will take seriously that whatever you have done is a valid evidence. Okay. the clinical investigation some other type. The very crucial, what MDR comes, is the first time that in Europe we have officially and legally the term sponsor. Sponsor is not only the company who pays the money for a study. Right now, European Commission, through the CARDIOCARE, is the sponsor for the clinical studies that you are running. Legally and lawfully. If you do not have this into your mind, you will be really surprised if at some point, touch wood, you end up to a court facing an issue with a patient or somehow or whatever, and start listening about the sponsor's liability without even understanding or even considering that there was a sponsor in CARDIOCARE. So please be aware and please take a good care of this aspect. The legal representative, it applies if you are running studies outside of the European Union. I don't know, I'm not sure if this is the case for you. You know better. The ethics committees, they are very clear for the first time. In the MDDs, there was nothing. In the MDR, still there's nothing. However, there is an article 62.3, all right, where it refers clearly why you have to take care about medical ethics committee and that you have each individual center has to fulfill all the national prerequisites for medical ethics, no matter what the European stands for, the European consortium stands for, all right? We are in the Article 17 for the first time, thanks God. They are trying to push the competent authorities that they have a role and they have some obligations, not only requests. The post-market surveillance plan, which is very clear, very demanding, very difficult to follow up for innovation, but still is there. And if someone believes that MDR is difficult for PMS, if you go to the United States, it's going to be a real fun. Believe me. Anyhow, the reporting adverse events and product problems, thanks God, through MDR and IVDR come up for the first time in Europe. So no matter if someone can complain about UDAM and whatever, still it's a very good beginning, and soon by 2028 we'll have some real data regarding serious adverse events, and incidents for medical devices in Europe. And also you have MDR described, it has a very clear format about compliance, how you can be considered as compliant, but also the audit readiness. That by MDR, you are the notified body, for example, or even the competent authority can come up anytime, knock your door with 24 hours notice, of course, for polite reasons, and say, okay, who is working with this CARDIOCARE device? Dimitris, okay. I'm gonna take the computer of Dimitris. Dimitris is sitting next to me, and I'm gonna go through the whole hard disk to see what you're collecting with, if it's the intended use, intended purpose of your innovation. So we have the reclassification of we have the expanded product scope. Okay, you remember MDR, IVDR. I think Constanza just mentioned this earlier on. We have the reclassification of the devices. Thanks God, for the first time we have common technical specifications, very crucial and very significant. We have the enhanced role of manufacturers within the development spectrum. We have the identification of the qualified person, the so-called QP, who is the registered person for innovation towards the bodies. We have the UDI, as we mentioned before. We have more rigorous clinical evidence. We request systematic clinical evaluation, especially for the IVD is non-exception at all, at any kind of. We have the notified bodies, the involvement of the notified bodies, and last but not least, the involvement of the distributors, meaning that the whole supply chain is responsible for the circulation of a medical device in Europe, and not only the manufacturer. So that's the policy-oriented framework, all right, that comes up with a process which comes up towards the product, and the product is supported by organization all the way. It's a vicious circle that to remember. Definitely could be simple, definitely is complicated, and contains complex issues that I'm referring here. Remember that the medical device innovation is a complex issue. And the complexity of the systems has been thoroughly studied, and I don't think that there are any kind of arguments on the aspect of this towards the medical device. Since we are located in Brussels, the meeting takes place in Brussels, I think that it's very common that these buzzwords bingo carries the successfulness and the necessity of the medical device innovation in Europe, and is fully accepted everywhere. I think that I will try to keep it simple and finish here, but just remember that MDR is not that far away than the rest of the regulatory bodies in Europe, in the rest of the world. The best paradigm is Australia. TGA is working perfectly well, and it has adapted MDR and IVDR in a more comprehensive manner, and it's doing greatly. The rest of the countries, they have their issues, but they are coming up. Just to remember that FDA finally has accepted that by 2026, ISO 13485 will be the only prerequisite for a consortium of whatever, for an organization to be characterized as a legal medical device manufacturer. So that's a great success by Europeans, that from now on, there will be only one ISO that you can prove globally that you are a legal medical device manufacturer. And definitely you have the following up benefits of ensuring the regulatory compliance. I don't think that you have any questions. Everything was in a great zone. Thank you very much.
Petro, thank you very much for this presentation, also going into treatment. As you see in the CARDIOCARE, okay, with our products that I try to define also for Paco, do you see any class 1 product out of those that we can leave, let's say, as a separate one? Because somehow, as we said before, we can make an offer to someone, but we did the CARDIOCARE, who is making the exploitation.
I think that whatever has a minimal risk could be a class 1. Definitely the platform which will accommodate all the modules that you are developing is going to be class 1.
Platform.
I can even design you the hierarchical tree which has to follow by classification 11, but it's definitely class 1. It cannot be something else. The rest depends on the evidence that each of the modules that you're developing will be sufficient enough and create any risk or create no risk or a minimal risk. But definitely the platform, yeah, by far. Now, if you are planning to have mobile applications for example, towards web-based electronically formatted questionnaires, in order to what Professor Tsakakis was referring that, okay, instead of having the assumption that a doctor has time to provide 16 questionnaires, and the patient has the time, and not only the time, but also the peace of mind to fulfill the 16 questionnaires. If you can come up with an application containing a validation questionnaire, yeah, it's a class 1, because it can create a patient's empowerment towards specific direction, because we're talking about chronic disease patients. And also for the commercial end users, as we call it in the regulatory field, the physicians, the experts, etc., to provide them with some kind of notifications in an alarm mode for exceeding limits that you have already predefined. So if the physiological, the acceptability limits have been predefined by you according to the literature, for example, and there's a derailment on this by a specific patient, a notification could go to his therapist or to his GP. Yes, this is a class 1. Because you are not misguiding the doctor, you are just notifying him. Now, if you come up with some clinical related information or molecular related information, then you are going above.
Okay, let's go to the next speaker, because he's waiting, Karim is waiting, you know.
And then perhaps we come back to Costanza after.
Costanza,
Yeah, okay, we can switch.
Okay.
Good.
So,
Karim?
if it's
Yeah, can you hear us?
Yes, hello everyone.
Wait, no, we can't hear you.
Karim,
Hello.
Yes, it works.
Hi Karim, how are you doing?
Hi Dimitri, hi everyone. Great to see you all.
Hello, Karim.
Okay.
Hi Kostas. I see there's also Manolis, a lot of familiar faces, that's great. Okay, so in the interest of time, I'll share my screen.
Before starting, say a few words about yourself to
I will introduce myself. Okay, so I'm a research professor at the University of Barcelona, Department of Mathematics and Computer Science, and I'm involved in a number of European grants, including with Dimitris, Kostas, Manolis, Elsa, including in cardiology. And I'm particularly interested in the concept of trustworthy artificial intelligence, and that's what I'm going to talk about today. So should I go ahead?
Yes.
Okay. Okay, so I will talk about trustworthy AI, also a little bit about ethical AI, because they are related concepts, and I will describe a framework to operationalize trustworthy AI, and then an example from a European grant on how we are doing this concretely. So why do we need trustworthy AI in cardiology? Because as you all know, the research output in the field is increasing exponentially. The question is how much of this is used in real world practice. Sometimes we hear of tools in the media. There's also a lot of attention on the promise of these AI tools that are being developed, including in cardiology. So these are two examples that were in the BBC and the Guardian. And in addition, there are some tools that have received clearance, for example, from FDA. So this is a website that maintains all the FDA cleared AI tools in radiology, including in cardiology. So there are more than 250 last time I checked. And these are in per anatomy and also in cardiology per focus. And now the color, what's important here is the colors. Green are quantification, image quantification tools. And then as you go to red, these are decision support tools, diagnosis, treatment planning. So there are a lot more of image quantification. And the reason there's a lot more of image quantification is that these are low risk AI tools, in the sense that, for example, for automated segmentation, cardiac image segmentation, the user can check the quality of the AI generated results and make corrections. So the risks are not very high, but it becomes high risk when it's diagnosis, treatment planning, and there are all sorts of issues that have been identified in the literature. There are problems of robustness, safety, security. We know that AI tools can have biases. People have have raised concerns regarding transparency, accountability, and so on. So trustworthy AI is simply tools that have certain characteristics. Some of these I already mentioned. They are safe, they are fair, they are robust, and so on, which makes stakeholders rely on them and adopt them in the real world. And these characteristics are application specific. So we know more or less what are these characteristics, but we need to define them for each application. So in the Future AI Consortium that includes all these individuals from all over the world, what we try to do is come up with a framework, best practices, to or step-by-step guidance to be able to produce AI tools that are trustworthy. So we did a literature review. We found that there were a lot of dimensions, a lot of characteristics that are related to trustworthy AI. We grouped them. Some were related, so we grouped them into a few terms to make sure that it's a self-contained framework with few guiding principles. So we selected these two, and then we added this, and then we changed generalizability, universality, and we came up with an easy to remember acronym, FUTURE. So in summary, we think that future AI solutions should be fair, universal, traceable, usable, robust, and explainable. So already we have some structure. We have the 6 guiding principles that can help us focus our design and development and also validation. And now what is the link to ethical AI? I think it's important to emphasize that the two terms are closely related. So each of these dimensions of trustworthy AI can be related to fundamental values or fundamental human rights. So fairness is non-discrimination, universality is equity, traceability is information, right to autonomy, right to safety, and so on. So we came up with a number of recommendations, best practices from this structured according to these 6 guiding principles. And now I will go through a few of them, not all of them, a few of them only as examples. And I will do this through a European grant called AI for Heart Failure, in which European Society of Cardiology is also a partner. And these are a few examples of best practices, things that we were not doing a few years ago and now we're trying to do. So at the design phase, the first thing to do is to engage stakeholders. So this is an example in this project of a meeting we had actually. I wonder if it's not in the same room where you are at the moment, perhaps, or close by. We invited all sorts of stakeholders, including patients, in collaboration also with the European Heart Network. And we try to understand their needs, their challenges, obstacles, what they would like to see in the tool. And this is very helpful later on to build trust. We had also other stakeholders in the meetings, clinicians, regulators, and so on. And in this project, not only we involved European stakeholders, but to increase the accessibility and universality of the tool, we also involved stakeholders from Tanzania and Peru. Another recommendation is to define sources of bias before you even implemented any line of code, to try to understand what would be the potential sources of bias. So, for example, we spoke to our Peruvian partners, and we at the Instituto Nacional Cardiovascular, and we asked them what would be the sources of bias in Peru. And we thought it would be ethnicity because it's a very diverse population. They have all sorts of Native American, Black, white, mixed race ethnicities, but also Asian ethnicity in Peru. But what they told us, their main concern when it comes to bias is actually altitude, because in Peru, there are people who live at 5,000 meters and others at sea level. So that's why it's important to engage patients and talk to them and try to understand the problem, including the sources of bias. And then understand also the sources of data variation. So, for example, we have cardiac imaging. What are the sources of variation? What the manufacturer, for example, of the scanner, and so on. But there would be others. And then define also the explainability method. So instead of enforcing certain methods, what we recommend is to show the existing methods to different stakeholders, clinicians, patients, and ask them what is the method that is most adequate for the application in question. So this is just to give you an idea at the design phase. some of the best practices at the implementation phase. Of course, now we have requirements in terms of clinical use requirements, but also explainability, fairness, and so on. So now we need to implement methods to align the AI models with the requirements, including the ethical one. And there are a lot of methods to do so. So this is a technical problem, but once we know what are the issues we need to address, we can choose what are the most appropriate methods. We also need to build human AI interactions. So this is the tool we are building. This is the design of the tool we are building in the AI for Health project that will allow adequate interaction, that will allow users to understand better the AI decisions and to enable shared decision making. Also, we're implementing ways to enhance data privacy. So we're doing this through federated learning. We implemented a network of GPU nodes across the different partners, and we're applying federated learning to increase data privacy and increase trust. So that was an implementation phase. The validation phase, what we recommend is to perform external testing. So in this example, we built a model in Amsterdam. We tested it in Brno, Czech Republic, to see whether it can be applied in different places. This is one recommendation. We also recommend to evaluate fairness. This is an analysis we did with UK Biobank data, and we found that the baseline model is actually biased with respect to sex, for example, income, to comorbidities, whether the patient has diabetes or not. And by applying some mitigation measures, we fix some of the biases. That's why it's important always to evaluate fairness. Also evaluate explainability. So there are questionnaires that can be used and including a system causability scale and so on. Now, finally, a last example of a recommendation that we have included in the future AI guideline is at the deployment phase to continue testing periodically. So we're building a tool to detect data drift and to see whether there is degradation of performance and whether we need to perhaps fine-tune the model over time. So take-away message from my presentation, just to say that trustworthy and ethical AI are important to ensure adoption in the future. And we have developed a code of practice toward this, which recommends a number of things, including engaging stakeholders, defining the requirements according to different dimensions, implementing solutions accordingly, and evaluating all these different dimensions continuously. So we have 6 guiding principles and the step-by-step best practices that I illustrated. And importantly, it covers all the stages of the AI life cycle. So trustworthy AI is not at the end toward validation. It's something that needs to start at the requirements analysis phase. And that's something that continues once the tool has been deployed and used in practice. We have a website. And if you go to the website, there's a link to a preprint that you can read where there's a description of all the recommendations this time. And just to thank all the co-authors of this work, that was really very much a team international effort. And thank you for your attention.
Karim, thank you very much for that, for your presentation. Okay, and the outcomes, from the recent heart failure project that you are running. Okay, any questions for Karim? You have seen what is going on with the future AI and all this work around it. It's a very useful suggestions, Karim, for us too.
Thank you so much.
For implementing the CARDIOCARE. So we'll try, soon to demonstrate to you how we're implementing our AI models and to see what data do we have available. Because, another thing that I wanted to discuss with you is the old discussion that we had that we started with Yana Maketonska, you remember, about the data preservation and all the stuff that you're doing there. Because this is part of work here. We're collecting a lot of data. We have a study with 750 patients, which is, a lot, and actually a very difficult study because we're collecting a lot of data, It's a very tough study.
Right. But yeah, definitely. Let's continue the conversation.
Yeah.
at
Okay.
another. And Manolis and Kostas, I'll see you next week in Greece. Goodbye.
Ingrid, bye-bye. Looking forward to welcome you.
Not
Me
me,
too. Thank you.
not me, Karim. They have excluded me from that meeting.
Yeah, we only have special guests for you.
Yeah, paying. Okay. Okay.
Thank you. All right.
Thank you, Karim.
Thank you,
Keep
Karim.
in touch. Goodbye.
We have now Constanza to continue. Actually, the meeting next week in Creta is about the breast cancer project, but different approach.
This one?
But then they expect it to change. Hopefully it will be, there is more reason, because I mean, yesterday when we and even Netherlands.
So much rain.
The last one.
Yes, this one.
It's going page.
While Nicola is preparing, the presentation, there is coffee outside, so if you like to get some.
For an hour.
It was a wild field, it's
Yeah,
forest.
yeah.
and-
Now we
and
start.
party, no, there is a pond.
If you want to go,
Yeah, exactly, so at night you can hear the water.
Yes, yes, yes.
Okay, perfect.
Coffee for you.
Okay, then we short break.
Yes, okay.
Okay.
Very short break.
1 minute to start, just to get the.
We won't have a whole other lake.
Make it two, come on.
2 minutes.
I'm going to grab a book.
Yeah, take your seat. Thank you very much.
Without that.
We got all of them. Send that in.
Yeah.
Perfect.
Yeah.
Thank you.
I'm trying to have
And
or any other activity just to student congress.
Quindi bisogna sperare che
Sì, un'ora penso comunque che
I like it.
You want me to close chiudo la porta?
Actually, yeah. Here's Costanza, go ahead.
So just again, a list of the project outcomes. In black, you have the software, so what fall into the devices, and the other two.
Maybe you can let me know
discussion we have
who
today. I
spoke
was
with from the
wondering
company
if we
already
have
so that I can.
additional outcomes, which maybe, I don't know if we can even think that the combination, the ecosystem of the multiple devices or solution can constitute an outcome per se. That was something that I was thinking. So combining multiple devices will be an additional outcome. And that one may be linked directly with the cost effectiveness study, because there is also this cost effective work package that is related to the model. Probably if we consider the entire ecosystem, it's the model, I would think. And the other outcome that I was thinking is the validation of the concept of using intervention to mitigate behavioral risk, even though the intervention that we are proposing and the triggers are not the final one. So we are not using a final prototype, but maybe we can still validate the concept. It's not going to be a medical device, it's something else, it's just so this is the list plus these two more theoretical one probably. Okay, so for what concerns the model and algorithms, these are based on two sets, as discussed before. The retrospective study includes more 1,600 patients, mainly clinical data, Of course, as many retrospective data set have some limitation because some data are collected in different ways in the centers and some data are more represented in some centers. And then there is a prospective study that we discussed before, which include clinical and non-clinical data. So apart from psychological status, we have omics and we have all the device data. The main algorithms that we are going to develop is the one for to detect cardiotoxicity risk, the risk of developing cardiotoxicity, and that one ideally should inform the treatment, so may impact on the choice of the oncological treatment. The second one is about patient monitoring and is based on what Manolis described before. So it's not only monitoring the cardiotoxicity, but the general status of the patient. So it's more linked to quality of life, vitality, intrinsic capacity. It's more on the general state of the patient. And so the main point now is how we develop these preliminary outcomes. So this can be software as medical device, standalone or integrated in other software. So I was wondering, so in any case, in the project, we will have only preliminary evidence, but I don't know if we can discuss on which, according to your idea, would be the most feasible pathway to product development. Because in case we have a standalone software, probably we need to have an entity that takes the leadership of the development of the validation. If we foresee also integration with other solutions, softwares already established, we can also consider co-development of partnership, etc. And the other point is about open access algorithms, which can be, of course, any open source software, but also publication in open repositories to leave the knowledge to someone else that will be in charge of validation. And another possibility is just to go for publication of the risk models, like for many other cardiovascular risk classification, like the Framingham risk score. We can only end up with risk scores. This is also another possibility, in my opinion. It's simpler because we also need validation, of course, but we don't need to follow really the entire pathway for product validation. So these are different possibilities. We also foresee strong differences in terms of effort, both in the clinical validation and in the manpower and the cost.
Can we ask or?
Yeah, I think we can discuss.
No, to what extent? Because before you said no. First, we disentangle the business model from this decision. In our case, when we are facing this type of problems, we don't.
You don't disentangle?
No, because they are depending on the status of the consortium or the leadership in the consortium. They are critically linked. So.
I agree. It's also for me, I don't see how we can really do.
And then the other mitigation measure we normally use is you don't know, let's not break it. In the sense that, look, I don't know about the future. I know about let's say the short term. Let's keep as many options as possible without taking any path that can destroy the next steps, because and then the other thing we normally reflect or talk or discuss internally is the different pieces and the different integration of the pieces in different ecosystems, because the products you put, each of them, they can have a different type of business model and therefore a potential way of moving them forward, that they have pros and cons. So yes, and also we see that normally we do not reflect enough on the value of the data we are collecting. Because we think about the end product, but we do not think about the potential value of this data that is quality data, well tagged, well analyzed, well curated. And this could have more value than a potential mobile app. Why? Because you are setting up the scene, and there is where the open source may have some potential. I don't know if I'm thinking too much out of the box or if it's useful. Because
Personally, I totally agree. The value of the data once collected and making sure that the data is complete, not a lot of missing data, well curated, etc., it would be extremely valuable for other people as well, for the community to continue and exploring, developing similar models or better models or other models, etc. So in terms of exploitation, the data itself is, I mean, for Karim, for example, I met and we collaborated for the first time with Karim when I was coordinating the project called, and I'm still doing, the project is still running, Pro Cancer Eye, and he was coordinating another project called EU Karim in the same call, which was imaging and AI in cancer. So basically the 4 projects that were funded generated repositories of highly curated imaging data in different types of cancers. We focus on prostate cancer. He was focusing on breast and colorectal and other types of cancer. So a value per se is the data set.
So no, and also it has, I mean, I'm not talking just in terms of research and innovation. So there is a community of research and innovation for free, but I'm talking about commercial value of iteration of additional algorithms or testing sandbox or data test bed for potential more than the.
We could possibly run into ethical aspects in the sense that we possibly need to extend the informed consent of the patients to provide it.
I mean, this is for sure, but so you would suggest that like additional, and it's not the data set itself, but like the possibility to run services on the data that are gathered.
Correct. You are not selling the data, you are running services on a well-curated data set with potential to add more layers, more because yeah, just keeping the discussion on whether we have a medical device or not, I think is pertinent. I mean, you have to discuss, but I think sometimes we restrict ourselves too much because we are not able to see the new business models around around data. It's just we see the app.
Then you're thinking in terms of the TEFs, of the experimentation facilities. So maybe we could collaborate with them and maybe they have the interest to, I don't know, use our repository or become somehow associated with the TEF.
I don't know. It's very nice to be here and become an expert instead of being in your shoes. That is normally my position. What I'm saying is that sometimes when we discuss these things internally, we just are like this.
Yeah.
And sometimes there is life outside the mobile app or the platform. And sometimes if there is not clear path to the market, because it's not my job, I don't see the revenue, I don't see the business model, maybe working around what we know that is the data well curated it's a possibility. I'm not disregarding the other possibilities. What I'm
No,
suggesting
absolutely.
is
So the structured data set we have, it was very interesting also what you said before about the European data space, but for example, we have some limitation in terms of data use because in the project, we have a data sharing agreement, for example, we have a DPIA, and in both of them is mentioned the fact that the data are used for the project. The main issue is about clinical data. So the clinical centers share their data to be used in the context of CARDIOCARE. So I wonder, because as all you know,
even if the data is anonymized and so it's the.
So I wonder if there is a way to overcome this restriction.
Expand.
That's $1 million question.
But you can always expand the.
Multi-million-dollar question, I would say.
Expand the data sharing agreement, like a revision of the data sharing agreement.
Even Karim that spoke before, he has run to the same problem, and my knowledge with ProCancer will run into the same problem. How, I mean, secondary use of data, even if you anonymize it completely and you prove that there is absolutely no way to re-identify patients, a lawyer can still find ethical issues that the patients had agreed for a specific project, to share data, and it's questionable if other projects and other forms of exploring the data would.
I mean, this depend on how you write down the ethical approval, for sure. Okay, and then you can always the new regulation. It's talking about data altruism. So at certain point you can request like fully anonymized data set, blah blah. It's you give it to science. So from now on, comply with the regulations. You don't have. I mean, think about how many times we click on buttons and we don't know. Yeah. I mean, sometimes we are being just. The problem is that we are using we are putting data protection in the informed consent. Informed consent was used to take trials and things that it could harm you. You know what I mean? So we may need to disentangle the informed consent from the data protection. But anyway, this is a different story.
So but in any case, we need to address this limitation that we have. We need to see how. And also another point is about how we, in the future, how we see the long-term sustainability of this data set. If we want to engage, so for example, these are 3 platforms that share clinical data. These are all of them use an approach that is based on a research sharing agreement. They ask you for a project. They allow you to use to receive some data if they approve. So there is a revision. You don't really download the data like an export. You go through a revision process, and if they think that your research purposes are in line with their mission, they ask you to sign an agreement and they can send you the data. I think that all of them are for non-profit purposes. I don't think that they allow use of data for commercial purposes, even though I don't know how they can assess really which will be the real use. And so a possibility is to engage with them and see which are their requirements, because they will probably have specific requirements for the data they store, or create a new platform for CARDIOCARE and be the owners of the platform, which in any case will create additional issues like organ management structure, who will be in charge of long-term preservation of the data, and this type of stuff.
Another question, and maybe it's for you, Petros. Is there an option with the current medical device to do just the the risk stratification algorithm as a medical device, just the formula, not the machine running the formula.
Yes.
This is another option because you can, hey, just the formula. Where you put the formula is up to you. And then I can guarantee that the formula does what it says and this and this and that. If you put it into a mobile, into the decision support system, it's up to the third party. But you have a
the
strong
algorithm.
position because it is, the formula has been, no?
Validated.
Ricardo, we spoke before during the interval about the oblivion right. So in Italy, it seems that collecting data before 2020 for patients is admitted only if the patient is in agreement with this about the data in the national health system database. If you are a cancer patient cured in 2019, have the right to cancel all your data inside the national system database. Is this a regulation only of Italy? And this may impact on the IEO retrospective data? Or there are any other kind of similar regulation in other European countries?
I think in all the GDPR allows the patient in all cases to withdraw their data. They have this right. Otherwise, is that the system has in place the mechanism to make it happen. But what you are saying, it's a right from any individual. The problem is that the systems, okay, I start deleting your electronic health record. I don't have a way to delete you. And then it has consequences because if I delete you, at least in other countries that we have studied, I may compromise your access to healthcare. Because if I delete all your historic data from the electronic health record.
It's the patient that is deleting the data.
No, it's not the patient, it's the healthcare professional. In many cases,
it's the patient that may require to be cancelled.
Yes, this is a right that we have under the GDPR.
And what is happening to the retrospective studies?
The patients have individuals, we have the right to delete the data that we request.
So for the retrospective data, we need the right of the patient.
Yes, but this is it's very unlikely to happen.
But still, it depends on the way that you pseudonymize or anonymize the data. Because
sorry, I'm not heard.
The pseudonymization or the anonymization depends on the. Meaning that GDPR as well as HIPAA is very clear on that, saying that, all right, for example, you are collecting data right now. First of all, the consent form that the patient has to sign, he has to put clear that he is allowing his data in a fully anonymized format or whatever to be used for other research purposes. Right. This is standard procedure, a European procedure, and has been adapted also Switzerland, Swiss Medical Data Act. For the, as Paco said, data ownership by default is fully on patient. All the others are co-shareholders. However, the patient, if in your repository you have 1 million patients' data, but you have declared your anonymization process and it was approved, then no one can delete this kind of data.
Because it cannot be identified,
exactly.
Because it's anonymous.
Exactly. So the right that you are referring is only applied to the EHR records that was shared with specific doctors on an individual basis, or somewhere that the consent form was not the proper one. Because the consent form, no matter if I'm not talking about MDR or IVDR, it's the good clinical practice, which says clear that but we have to declare in a consent form in the local official language of the country. And we have the right as a sponsor to add this, and the patient settles either A, that one to provide the data only for CARDIOCARE, and this is it, or I'm allowing in a fully anonymized format this data to be used for other research purposes.
But let's say that for the data that are already collected in CARDIOCARE and are part of this retrospective data set, I don't think that exists the possibility of having some records deleted because are already in our data set, and we don't know if the patient today decides to withdraw the data. At the moment, I think it's the way it is.
But it's not the key is if it's anonymized or
It's
not.
anonymized, of
So
course.
there is no problem. There is no way because otherwise
Exactly,
you are claiming I did not anonymize. If you are able to.
So it's there, and so we assumed at least at the time when they shared the data, they approved, and now who knows? Maybe for future study it will apply, but not this. But in any case, also this is.
But why you cannot use this data set that you're gonna create? For example, adding this, co-sharing this with royalties to pharma companies, for example. If they wanna find data to run their bioinformatics models, for example, which is a standard procedure nowadays. They are renting, they are paying.
So I think this is also, I don't exclude that this is possible, but in all our forms, we always mention that is no profit research, is a research project. So there is no specific instance related to the commercial use. So also in that case, for commercial use, I think we should amend the data sharing.
But he's not saying I give the data to a third party. He's saying I run a study, correct me if I'm wrong, on this data. It's not selling the data.
Yeah.
It's selling a service on this data, which maybe, I mean, it's.
You're not even selling the data, you are just co-sharing the data.
Yeah, I understand.
And the profitable aspect, it's not related that, okay, I'm getting some money, some reimbursement because of my service, because European Commission pays you as a partner as well. So it's for profit because you're paying your salaries. But it's meaning that you cannot declare the legal format of CARDIOCARE or whatever profits based on the income of potential co-sharing agreements with Roche, with whichever pharmaceutical would be interested. So for me, I don't see any problem to create or even to use European Society of Cardiology. I think it's a non-for-profit organization even. And it can declare, it can provide, according to an agreement between the partners of the consortium, specific pre-arranged funds, reimbursement for it.
Okay, so this was about the data, and then the other aspect that the research process we already discussed. And for the ML solution, that was something already discussed. So we have two different apps. The one that's called Ipsy Heart is probably a class 1 because it's basically to collect information. The other one provides intervention, suggests behavioral intervention. At the moment, some of these interventions are.
Which one is class 1?
The first one.
The psych heart.
That one just collects information.
Yeah, but it says inform patients on the overall emotional, functional, physical well-being. So more, it's not does not provide the signal that Professor Siknakis is collecting.
No, but it just provides the results of a questionnaire, basically.
But based on an algorithmic analysis with a score. I mean, what?
No, that's
a score of 120 what is the point?
It provides the scores for each
Just-
validated question.
Questionnaire, so it's
It's a
like,
communication tool that implements standardized questionnaires.
The questionnaires are validated already.
yeah, these are psychological
It
questionnaires.
gives a score, the final score.
Yeah, but this can be translated to the health status.
Yes.
These questionnaires, they have, it's like.
But they're not ours. They are
Yeah.
standard of care. So we collect information according to the standard of care. We just do it in a digital form instead of patients going to clinicians
Yeah.
and clinicians writing down the answer.
EQ5, is EQ5 a medical
Exactly.
device? The fact that you put the EQ5 into a mobile makes this a medical device. Just, I think, I mean, when I understand class 1, I think like people are using class 1 as,
Yeah, I think that is very low. I mean, the risk for this one is
Look,
non-existent.
based on the way that you're describing, you can put it not even as a non-medical device. as a
Exactly,
communication
exactly,
tool.
even as non.
However, when we shall see the final intended use, the final claim of a product, a bicycle can be characterized as a bicycle, when we see that this is supposed to be sold as a bicycle. This is the claim. And this is obligatory to carry a CE mark as a bicycle by European Commission. So the claim is not clear there. So this is an assumption that I can easily say that it is not even a medical device, because by MDR, a communication tool is not a medical device.
Okay.
And that was the problem. And most of the telehealth companies, startups, they got bankrupted because they never could get reimbursed.
So yeah, this one is basically like a tool to provide, to collect digitally some information, I would say. The second one is much more critical because that one provides intervention, I mean, low risk intervention. We are talking about games, we are talking about some task, they ask you to conduct some task. And at the moment, some of these interventions are proposed at fixed time points, while others are proposed when certain levels of the risk in the questionnaires are reached. But of course, in the future, this type of intervention can also be, let's say, recommended when Manoli's risk appear high. So in the future, right now, these are proposed based on questionnaire risk levels, but in the future, the risk level may be derived from a machine learning application.
Class 3.
Not two.
It's not.
Class 2 what? 2A or 2B? Because if we're talking for cardiotoxicity means a potential heart attack. That goes to B. If it is not related to cardiotoxicity, but only to the cancerous condition of the disease progression of the health status of the patient, could be class 2A. Or if it's it can have parameters related to terminal damage, it has to go to class 3. So it all depends. Right now, you cannot even claim this because you don't know what the data that you're going to collect finally,
it's true.
and also the final solutions by the guys.
No, absolutely, absolutely.
And it could be a quit smoking app, well-being, because
it's also possible. It's also possible. Let's say that right now, such interventions are used in the context of the study we have been discussed. And in the context of this study, which is a weird situation because this study, our prospective study, is from one side a study to collect information on cardiotoxicity risk, and from the other to prove the concept of behavioral intervention. So it is a randomized study, even if it's if we don't have it's not a pivotal study, but it's still a randomized study. So in the control group, we do collect information from the app, mainly psychological, etc. And the intervention group, we also suggest the games, the whatever activity, task, additional. And so it's how they are currently used. That's just to show you how this type of intervention are currently used. But of course, we are still collecting the information related to the potential efficacy because we don't have. So it's a little preliminary to say what will be the final claim.
But this is what I was discussing in the, I don't know, during the morning when I asked you about the intervention and so to what extent the intervention can contaminate the results of the preliminary study of the toxicity?
It could, because in fact, one of the points is to see if the group, if the patient in the intervention group, if the risk of cardiotoxicity is altered in the intervention group. So in theory, we expect a difference, a mitigation of the risk. But of course, this is a possibility. Of course, we also have to say that, as previously mentioned, we do have issues about compliance. So for some patients, we don't have information about the use of the app. So we cannot claim that they are under real proposed intervention. So we have control intervention and the subgroup of patients which are out, in which we will basically collect only biomarkers of cardiotoxicity.
Which is the percentage of the responsiveness versus non-responsiveness?
It really depends across centers. And also, I don't remember it right now. And also it depends if you consider all devices, apps, wearables, we have mixed. In general, we have some improvement now compared to the first patient enrolled, because the centers are providing more support to the patients, basically.
I think, but please bear in mind that above 10%.
It is above 10%.
You might have an issue in the future, because they are not only ongoing audits, there are also retrospective audits. And as you know, any percent that's above 10% of missing data, manipulated data, etc., corrupted data, etc., is not acceptable. And that has an influence to the validity of the clinical, of the primary endpoint of the clinical study. And this is not in Europe, this is not in the United States, that's everywhere.
Yeah.
This is a fight every week, with the clinical partners. We provide, the data that we need.
So do you mind to go 2 slides before, because I want to say something. And Apollo, no, there, yes. So there, what do you mean age-associated conditions?
Age-associated conditions are, for example, comorbidities like urinary incontinence, sight impairments.
All right, okay. The thing that I want to tell you, my suggestion, don't take it as granted. However, this is a multimodular device, right? Multimodular device means different devices in a single module, if I can rephrase it. And this is both sides of the Atlantic. It's not that Europeans came up with such a concept. Now, preventing falls is an app that all of the institutions they are looking for.
They will buy it directly.
So it's a single device. In general, in medicine, we do not use multi-mixer because we're not baking. Right? That was the slide that I showed to you, and that's why I said that medical device technology and development is complex problem, and it's not other classification. The complexity is very clear. You cannot have different major claims in a single device, never. And you know why? First of all, there will be no HTA in South Mediterranean, in our places, that we will never accept. Not even in Switzerland, I cannot, because I'm not an HCA expert, but definitely for some markets that we are collaborating, never will be a green light. So prevent falls is a single one, period. Support caregiver, it's a totally different aspect, different. Does not have anything to do with the disease per se. It's for the support, to support the caregiver. Support caregiver, if I can translate it in medical terminology, could be the burden that the caregiver is facing, which is in many diseases higher than the patients. Anyhow, improve mobility and vitality could be along with the well-being, as Paco said, right? Which is straightforward, not a medical device. You will never make money, but at least you will start having a branding name. The managed age-associated conditions, I'm not convinced because it's related to medical conditions that you were not clearly supposed to collect this data. Because CARDIOCARE is referring to cardiotoxicity for breast cancer. Now you are referring, for example, that for other comorbid conditions. These need to be further exploited. I'm not saying that you cannot do it, but further exploited. And if so, please make sure by your partners that you collect sufficient data. Sufficiency with 700 patients that you are claiming to come up with so many devices, I would say that it would be a joke. Anyhow, if you can make it, it's good because then you can publish and finish up. It's too low. I mean, the numbers are very small. 750 patients with a dropout rate, more or less at the end of the day by 25%. What kind of power analysis gives you, will come up with such kinds of robust evidence? But this remains to be seen.
But we can, for example, consider that it's let's say it's an exploratory study for this device. So we collect.
I'm not saying that you can do whatever you wish.
No, but I mean, it's the aim is to see if so we are collecting multiple endpoints, it's true. Also because they are all related to this intrinsic capacity we have been discussing in the projects. But maybe in the future release, let's say, of the app, we will end up with an app that is more focused on a specific condition, because maybe this app will not work. I suppose that maybe it will work just for one or two.
In medicine, we are looking for simple solutions, simple, clear solutions. If you put 10 parameters, you provide them 10 solutions simultaneously. It is too much for the doctor that he doesn't have the time to go through it. I know a medical device company which has a brilliant outcome report, a continuous monitoring system. I'm pretty sure that there's no one doctor in the Western world that has time to go through this report. Right. So make it simple. I prefer to have 5 different devices of a lower impact. That's the only issue. But to be able to go one step further for the quality of life on an individual manner to the patient, right? Instead of having something, a complex claim that a reviewer cannot understand really what is the actual benefit. That's my advice.
Pedro, that's correct, okay, but when you are writing European project proposals,
That's how you should do it.
it's a different story.
But this is why you are so successful on this aspect. What I'm saying though is that
if you go to the next step,
yes, if you want to go to the market, you need to
no. If you go to be realistic, I mean, the reviewer at the end of the day, he will never understand. Okay, that if I provide him 5 different devices, 5 different solutions with 5 different claims, would be that significantly different than a combined one.
Just
For him, it's the same. He has to review each individual parameter. That's his job. That's why he's getting paid. But the final outcome will be of less power. That's what I'm saying. On the contrary, if you have 5 different aspects, you have higher power per each one. You're not changing the proposal that you have submitted at all.
No, we're not changing the proposal, but in order to get the proposal,
As
you
I
have to
said,
write
this
all
is why you are so successful, and this is why I'm always respecting your approach. But now the project is ongoing. That's why I have the flexibility to speak out. Otherwise, no.
in any case, I'm
Constanza, just
I'm
sit up
finished.
because-
I think, yeah, thank you. It was
Okay. I think that very correctly also you pointed out so biomarkers. But in addition to the 4 items that I pointed at the beginning, so sometime we should discuss, I don't know, maybe with Petros, what is qualified biomarkers.
Biomarkers, no, it's very straightforward. Biomarker is whatever is related.
Not qualified, you know, the FDA terminology. They have a list of qualified.
No, the qualified biomarkers by FDA was a legal obligation by the capital because some legal guys from Washington, they came up to FDA and say, okay, there are thousands of products in the market. They're not regulated because they were not supposed to be regulated. But everybody is going to see if you're going to develop cancer, prostate cancer, whatever cancer, whatever, etc., etc. So FDA came up and say, okay, who has the most publications, the most powerful literature support? So they make a block, and automatically these were by FDA the qualified biomarkers, which are not going to be equivalent companion diagnostics that I was discussing earlier on. For companion diagnostic will be directly reimbursed in equivalence of medication cost. And the medication cost is we're talking about because you are changing the whole landscape of medical devices development. Total. And this is where the therapeutics of medical device comes. So the whole clinical approach is changing. And this is not the future, it is ongoing. Right now, BSI has cleared 2 products, TIFSUIT has already cleared 3 products, one we were involved as well. So it's ongoing.
Let's go ahead.
So I know everybody wants to go home, so I'm going to be quick.
No, we love listening to you.
So for the people who don't know me, I'm Anka. I'm a data and AI researcher with Philips. And for this meeting, I had looked at the AI Act and the impact that this AI Act is having in CARDIOCARE. Let's see if this works. Yeah, so you already know that CARDIOCARE is going to deliver a lot of output, and I hope that the speakers before me convinced you that those are valuable. But of course, this will only create value if they are used beyond the project and by people outside of this consortium. So our sustainability really relies on our ability to be compliant with the regulatory frameworks. And because we actually have AI systems among our outputs or tools that include AI systems, of course, we will be subject to both MDR and the AI Act. And what is different actually for the AI Act here is that it does not cover only things that we want to commercialize, but also actually covers use of any AI output. So yeah, I think this is not a surprise to anybody. You looked at the AI Act. It's a risk-based classification. The higher the risk, the more requirements. The highest risk basically means will be forbidden in Europe. And that's also very interesting that this legislation applies to both the providers of the tools, so the people who make the tools, sell the tools, but as well as the deployers, which means that even if we come now and say the European Commission, the hospitals are going to use our tools. In fact, according to the AI Act, if we are not compliant, they will not be able to use them. So this is very, very important to keep in mind. And yeah, of course, these are the levels of risk. In any way, as we discussed, the tools that include AI in our project will probably be in the high risk category, so they will have compulsory requirements. And yeah, so the AI Act will be published this month probably, and then this high risk requirements will probably be in Annex 3. And this will come into force around 2026. So we may say that this is far away from the perspective of CARDIOCARE, but if we don't take it into account now, by the end of the project, we will figure out that we missed things that were really important under the AI Act, so that all the work that we have done would have been for nothing. And another aspect that I found interesting in analyzing this is that this actually has impact also on subsystems that are not directly under the AI Act, such as the platform, the data management components, and the data and how we manage, how we deal with our data. So with respect to the key requirements, overall, there is an overlap between software as a medical device and the AI Act. However, the risk management under the AI Act includes additional aspects, for instance, looks a lot at ethics and fundamental rights, but also asks more from data and data governance, human oversight, as well as logging over the lifetime of the system. So basically, for instance, requirements towards the data that we use for training, testing, and validation are quite strict with respect to the fact that we have to detect bias, to see if this is free of bias, data quality, is this fit for purpose? All this have to be taken into account as we develop the models from the beginning, and we cannot say at the end, like, okay, we'll do it later. And it is expected that we will have documentation that covers the design choices and all the issues that we have found in relation to the data. And there is also the requirement in the future that we should provide access to data for the notified bodies, which is quite challenging as a requirement. So yeah, now looking at our assets, of course, the analytics and the predictive models will be actually under the AI Act as high-risk systems. And here we have to, when we develop this model, we have to be very careful with respect to the data that we used, and that we are actually compliant with these requirements. And we have to be very careful with how we design our choices and how we document the choices that we have made while developing these models. And now, yeah, the mHealth applications, some of them can potentially be AI systems as well, if we think about systems or tools that incorporate an AI model, because it's not only the models that are being trained and continuously improved, but if we take a model and we put it in an application, then that application can become an AI system. So that's another interesting thing to consider, and again, looking at what design choices we make and how we are going to document these applications. But the more interesting thing is that impact on things that are not AI products in themselves, not AI systems. For instance, the CARDIOCARE platform components, I would say they are not AI systems in themselves. However, they are important in the sense that we have to make these particular developments and decisions that will actually support the AI components for the future. For instance, with respect to logging, this will be part of the central resources and other kind of documentation, monitoring. These things have to be incorporated into our platform, even if the platform itself is not an AI system, or even if we are not going to sell our platform beyond the end of the project, because we may actually decide at the end that the platform was something that helped us develop the models, but only the models will be further exploited. But still, that means that for now in the platform, we have to take into account some of the requirements that will become important. And yeah, of course, the data sets. So the data sets and the data, everything around data governance and data management. We need to be very careful the decisions we make and how we are documenting those decisions. Things related to data standardization actually can help us developing our data sets according to standards and in a harmonized fashion. This can actually help us down the road. And again, we do need to document our choices. We need to understand if there is bias in our data set. Is this data representative? Is this data of an adequate quality for this model? And all this we will have to be able to defend later. So from the CARDIOCARE perspective, of course, the legislation is not yet applicable to us, but we really need to follow, and it's likely that this will be translated into guidelines and standards, that there will be groups that will be working on developing new standards. And what we could do as a consortium actually would be to follow those developments. So in fact, for the review, for the European Commission, we cannot say, well, we are fully compliant with the Act right now because we don't know yet what it means. But for instance, if there are standards that are coming out and we are participating and we are connecting with those people, that's actually quite relevant. So basically participate in the standardization initiatives and collaborating. And of course, on the design, development, and the validation of CARDIOCARE, we need to do that with sustainability in mind, knowing that we will have to prepare. If we want this to live beyond the project, we will have to be compliant at that time. So as I mentioned, it's the data quality, the documentation, the design choices, all this we need to be very, very careful. So that's my analysis. I don't know, if you don't agree with me, that I would be very happy. But
since we are responsible for the platform, I would like, if you don't mind, to share your presentation with us. So
We have the presentation, Lorraine.
yeah.
You can ask Georgia to provide the presentation.
Very nice.
But I have a comment. Excellent presentation, excellent approach. I will get the presentation, not to cheat, but to learn. However, when we're developing something technological, to come up to your point of view, we have the regulations in relation to the claims, right? This could be MDR, which could be UACT for AI, but we have also the technological regulations. And technological regulations are the ISOs. If you cannot prove that the evidence that you come up is supported, not supported, is fully in compliance to the ISO XYZ, then you're not compliant. It's a self-claim, you're not compliant. What I have missed today, I don't know if there's any other presentation, but because Dimitris is well aware of it, there are some specific technical standards that they have to be fully deployed to the technology, and all the evidence which will be supporting the innovation, AI, apps, whatever, they have to come up with concrete evidence that these are compliant to X, Y, Z. You are the experts.
I believe you are referring mostly those to standards related, for example, to user authentication, ISO standard regarding authentication, ISO standard regarding security of data on the platform.
Yes, but also there's the new standard 4000 series, which refers to the AI purely, and this is certifiable. It's not a standard that you can claim that I'm fully compliant. No, you have to be certified. Secondly, from a consortium like that with a potential that this data set could be used somehow for profit or non-profit, that's your business, with European Commission, I would, if I would be the auditor, I would miss the ISO 27001, the new version of 2022 here, because I didn't hear anything about that. And there are two other related standards in AI that if Dimitris will request, I can send to him, because the first thing that you have to prove in a quotation mark is that you are technologically proper and comprehensive. And no one cares to go through your evidence of endless thousands of pages or Excel or whatever. No one. But still, they want to see evidence, certification. And so MDR or IVDR EU Act, along with the GDPR, okay. Unfortunately or fortunately, these are the four, but in the regulatory aspect of the outcome, of the clinical aspect. Before that, you have to take care of.
Petrus refers to several standards that exist, even for the development of software, for example. This is the 6000 series, the development of software. For the others ones, the ISO for the data, and the artificial, the 4000 particular, research institutes are not obliged to follow.
Yeah, but if you come up with a platform that Philips will support, for example, I don't know, the company per se has to fulfill the obligation. The obligation is there. If you don't have the certification, you are liable. No, you may never be bothered by anyone, but in case that then the whole.
Yeah, definitely. Indeed, so complying with standards that are out there, we should definitely do that. And for in the AI space, there will be new standards, and we really need to follow that.
Yeah, these three standards that I referred to, definitely they will carry on as a minimum prerequisites to be delivered by until 2028. So more or less you are fully covered. If something extreme is requested, you can always provide the state-of-the-art methodology and period. You are fully covered. But the three ones that I have in mind, because I was aware what they commit by EU is requesting.
27,001, 27,002, 27,005.
I'm slightly confused.
I will send you an email.
Because if we go to NIST, we see that NIST is currently in the US, that's NIST. And I'm in front of the webpage. NIST is conducting research, engaging stakeholders and producing reports on the characteristics of trustworthy AI. So they try, and there is a discussion document, and etc. So trying to develop methodological framework, metrics, etc. So on the other hand, we say there is an ISO standard already that we need to adhere to.
Yeah, but
and I'm slightly confused.
No, you shouldn't, because you are in Europe. In Europe, the American state of the art It's not obligatory, first of all. It is advisable because they have more experience and they are producing more practical approaches, guidance, etc. But still, in Europe, the ISO standards, they are superior to any other standards, either American or IEEE or whatever, or the British one, the EN. No. If there is, and the regulation is well defined on that, if there is an existing ISO standard, harmonized ISO standard, it is superior to any other standard, applied standard, or state-of-the-art methodology referred to any other part of the world. So you are in Europe, you have to fulfill European.
So you are saying that the standardization landscape is sufficient to support whatever the AI Act is asking?
Yes.
So we don't need anything else except for?
No, that's what I'm saying, in a polite manner.
Okay, let's see.
I have never had an issue with my client.
Okay.
That's good. And the issue, you have to start from somewhere, right? EU Act is a regulation which has yet to provide guidance, practical guidance.
Exactly.
How you fulfill. For example, when I'm going to Greece, I'm hearing, you know, I'm a fully GDPR compliant, but you cannot. You cannot. It's a claim. You cannot be a GDPR compliant. You are fulfilling the GDPR obligations. You are not compliant.
Yeah.
If you are compliant, when the case will be, the judge will address it because it's not certifiable. If something is not certifiable, you cannot claim compliance. That's why, for example, the regulators say for medical device, ISO 13485, period. For data security, information management system, ISO 27001 family, 27,000 family, because these are certifiable. Someone else has audited and gave you the certificate, not you. The ISO 4000 family that I'm telling you is AI.
You say that, you know, you follow the standard, and another is certification.
So which is the ISO standard?
I will send to Dimitris.
I will receive those. You will receive those. Now I think that we have reached to the end of the presentations, and we had very lengthy discussions at some points. You know, it's when you're going from a research project, the market, let's say, is different. Okay, and then you have to face the reality. Okay, that face a medical device company. Medical device company pays 20% of the annual turnover to follow the regulations and stuff.
More.
More than this. More than this. Of course, there are exceptions, Pedro.
When are you retiring?
Yeah.
When are you retiring?
Well, Pedro is 35.
So it's if we have time for him to train us to take over when he retires, it's a good business to be in.
It's a good business, not for us, for the notified bodies.
You know.
For this kind, no, for us, we are getting paid by month, because and especially my company, based on my decision, I prefer to have 70% of projects on startups, because I like creativity. I reached a level of my immaturity, emotional immaturity, that I need only creativity. So multinationals and big guys, that it's too much politics, is for younger persons, not for me.
Okay. And I think that we understand, okay, what we have to target. We have to clarify which is the outcomes from this project. It's very important. To make much better descriptions of what we have in our hands. In some of the ones that we proposed to be made medical device, we have to create intended users, at least to present the information. And then for each one of them to understand the next steps that we have to do. You know, today, you know, the meeting between researchers, people coming, you know, from the medical sector, and on the other side, people big, you know, real business. Okay, and okay, we're discussing, okay, that some of our products are medical devices, but you cannot imagine how far is from the time that you have something which is verified and validated to be in the market with a medical device. It's a very long trip and it costs a lot. Actually, to make a medical device, you know, an idea, a concept that we have developed in a research project, it will take from on the average from 5 to 8 years, and the cost up to 30 million, simple, say apps like that. So it's a very expensive sport. Okay, I have made, you know, several notes here, and closing this meeting, I wanted also to have Ricardo to comment maybe a few words, because Elsa announced that there is wine outside waiting for us. So Ricardo, if you'd like to make some comments on what we're making.
Yeah, I would like to say 3 or 4 essential words that we are putting in our bags as take-home messages. The first is data, data, data. In the field of cardio-oncology, data are gold.
Are?
Gold. Are essential, are crucial, because we still have not too many data to support a lot of issues in the field of cardio-oncology. So this project, involving a lot of patients, retrospectively and prospectively, is wonderful of just to have data. The second word is risk stratification. If you see the guidelines published in 2022, most of the recommendation about risk stratification are a class C of evidence. That is agreement between friends with very low evidence, level of evidence. Because we have one study about BNP, one study about troponin, 2 studies about GLS, and so on. But still, data about risk stratification are very low, and whatever study is able to bring more data about risk stratification is welcome. The third word is frailty and quality of life. In patients with cardiovascular disease, together with cancer, quality of life and frailty, I think, is quite important to know, because it's obvious. They have 2 conditions very impacting with their life. So to have clear data about this is extremely relevant. At the end of the story, if we are able to use digital health, that is the 4th word I would like to underline, well, thank you to digital health. We need to clarify probably more in depth some regulatory aspects that still are very complex and not complicated, as you underline, very complex. That may be very difficult to understand from the point of view of the clinicians. And so this is a challenge for the future, for the next future, tomorrow future. Well, I think that this is all. I would like to thank you everybody for coming here, and I wish you all a nice come back home and a safe come back home.
Thank you. Thank you.
Yeah. Ricardo, thanks for making those comments, especially for data. I truly believe that, and we put a lot of effort into that. It was very, very difficult to start even the clinical study. It was, for me, it's, a matter of losing my health.
Yeah.
Costanza knows very well my reactions. Okay, to everybody there.
I know.
Many people. It's very, there are two things. One of the things is the ethical committees that were very difficult to accept such a study with